All right, guys, come on in. Welcome, welcome. Very unforgiving. Yeah. All right, I think we have a critical mass. So we'll get started just to hopefully stay on time because we have a jam-packed day for you, which also includes hands-on training in many respects, as you see these lovely tables up front that you're going to enjoy during the break. But welcome to the 2023 Masterclass in Hyperhidrosis. This is actually the second time we've hosted. The last one was 2019, so the majority of you were not here. So this is all fresh and new. And I hope that a lot of information is relatively new information, because then you can take it back tomorrow to clinic to help the plethora of patients who are suffering with this disabling condition. Also want to wish all those celebrating happy Hanukkah. Tonight's the first night of Hanukkah. And I think that it's very appropriate, being the kind of festival of lights, that we're going to shed light on this condition. See what I did there? We are going to shed light on how to approach it, how to diagnose it appropriately, and of course how to manage it, because we have some really fun armament. If you're not familiar with it, for you to get these patients under control. I am Adam Friedman. I'm chair and program director here at GW. I'm joined by my co-director, Mary MAIBERGER, who is director of dermatology at the VA. Could not have picked and worked with a better compadre, as she is my program director sister from another mister at the VA. Our residents spent half their time there, so this was really fun to work with her and setting this up. You know, I also, before introducing our really incredible visiting professors, who I think laid the groundwork, continue to provide all of us with the how-tos for hyperhidrosis, I do want to give a special recognition to Lisa Peretti, who heads up the International Hyperhidrosis Society. And just to kind of relay a story, when she first approached us about doing this program, I said, I have no bandwidth whatsoever. There's no chance I could possibly do this. And hyperhidrosis patients are very fortunate that she's in this position, because she somehow got me to do this. And I don't even know how I'm here this morning. It's like all a blur, but her passion is really palpable when it comes to helping patients. And there are so many with this condition. So I just want to thank you, Lisa, for being a magician and making this all come together. Next, I want to give special attention and a huge thanks to our visiting professors, Dr. Dana GLASER and David Pariser, who really built this from ground up. I mean, if you picture one of those like Revolutionary War movies where it takes them like 5 years to make a house, and you see all those people like building the framework, that was them like patting the ground before even that framework goes up. You know, everything I think I know about hyperhidrosis comes from these two. And so we are so fortunate to have them here today to share their knowledge and experience with how to manage these patients. This is really boring stuff about CME. Yes, you get CME. Make sure you signed in up front. This is an accredited program. For you residents, you do not have to worry about this yet, but it is coming down the pike. As I mentioned, and yes, as being a CME program, we do have to list our disclosures. Mine are not here, but I do have them in my talks, not to worry. I am a transparent and translucent person, so that will all be in there. We have a lot to get through today, and this is going to be very fast, action-paced lectures, 10 to 15-minute lectures, going over a lot. But being in a small environment, I think there's a lot of value to that, in that don't be afraid. Come ask questions at the break. Chat us up. This is your opportunity to get that one-on-one, face-to-face time. So do not hesitate. But we do have a lot of objectives to get through. Oh yeah, there's another slide on that one. We're breaking up the day into several acts, kind of focusing on different flavors of hyperhidrosis, and then of course rapid hands-on training. And that's another opportunity to give a shout out to our patients who are going to, I was going to say donate their bodies to science. That sounds horrible, but they are going to make themselves available to enable us to better treat all of the patients out there with hyperhidrosis. with that, I want to give Dr. Maiberger a chance to say a few words.
Thank you. We really appreciate everybody coming out this morning and really excited to share with you some of the advances in hyperhidrosis and so that you really feel comfortable treating these patients and caring for them in clinic. So thank you so much.
Thank you. And with that, we are going to jump right in to try, and I air quotes, try to stay on time. So I'm going to start off by discussing how do we define and diagnose this condition and distinguish the different general categories, but then start to think about how can we maybe improve the way we diagnose this condition. So first off, I think it's so important, not just in terms of how we think, but how we talk to our patients. This is a medical disease. And that sounds so intuitive for all of us as dermatologists or dermatology practitioners, where we are in our training. But so many of these patients were told, it's just them. It's just like a weird thing. Suck it up. Don't worry about it. But I think even I've told patients, there's actually a code that I can put in the chart that allows me to get paid for taking care of hyperhidrosis. That sounds kind of weird, but it really is somewhat validating that this is recognized as a medical condition. And I think the first way we would identify and define it is that this is 4 times the amount of sweat needed to regulate body temperature. So yes, we all need to sweat. And that's part of the difficulty here is being a kind of invisible disease is where do you draw that line in the sand to say, this is normal sweating for thermoregulation. This is something pathologic. I was just having a conversation about how I kind of define that. Well, if who's at home relaxing, watching me, and they're still sweat will be needed. That's maybe a good point. But I think it's hard to say, oh, it's needed. I mean, kind of comprehend that. Some other things we can do to think about how to define this condition. This is a relatively common condition. The prevalence is pretty high. The historical data, puts it at roughly about 2%, but more recent, it's probably about double that. So we're talking about a condition that is more prevalent than psoriasis. And I don't want to hate on psoriasis, but I feel like psoriasis for years has gotten all the attention, probably because there are like 1,000 drugs for it. But this is a very common condition that does not discriminate across age ranges. And actually, early onset in maybe adolescence or childhood, is kind of part of the way we think about defining this condition. And to that point, we cannot forget about the kids. And think about, there are a whole bunch of residents in the room. It wasn't that far away. Think about your adolescent years, and maybe put in modern era, and everyone has a smartphone or an iTouch. Think about, Palmar however, being able to swipe left or right, or put in your password. Holding the first hand. I say holding a pencil. Who does that anymore? But it's even sports, in terms of catching a football, throwing a baseball. There are things that are very prevalent in terms of daily activities that will change throughout one's life that can be tremendously impacted by hyperhidrosis, let alone the social ostracism and the visible nature of this condition and how it impacts someone's decision-making. Now, I don't want to always be a pessimist, so I want to find maybe something that could possibly say, yay, excessive sweat could be good. This was one random tech thing, but to be fair, I think we have to really put into context the impact of this condition on the patient. And to that end, I think hearing from patients is really important. It's always good to ask, how does it affect you? And often patients won't even bring it up. I feel like I pick up more hyperhidrosis patients on skin cancer screenings than actually them coming in with this being the chief complaint. And the first one is actually the second bullet point, which is, I am so sorry. I'm sorry I'm melting away this 2-cent gown that you gave me. Thanks, by the way. I'm sorry that I'm sticking to the paper. There's usually a apologetic component to it, which kind of gives you insight in terms of how horrible this is. The fact that they have to apologize to their physician, where they should feel the most comfortable in that circle of trust. But then getting to, right, what is it really doing with respect to their daily activities? Now let's get into defining this. And I wanted to start with secondary hyperhidrosis first, because this is an acquired condition. It is, as the name infers, secondary to something else. The way to think about it is it's typically generalized. it never stops. It is relentless, and that adult onset. Now, for some patients, it's hard to, they come in, they're like, I don't know, maybe I had this as a kid. The recall element can offer some bias because maybe they were just told, don't worry about it. It was normal. They kind of put it out of their minds. But the fact that it doesn't stop while sleeping, I think is an important point, and the generalized nature of it really stands out. There are a lot of things that can do this. Medications, underlying medical conditions. I do want to point out, though, that we shouldn't just assume some of the more common things. And I know patients with primary hyperhidrosis were maybe told, oh, it's because you're overweight. Oh, it's because you have diabetes. That is not okay. I think it's fine to go down the rabbit hole and try to assess, based on the clinical features and the history, is this being driven by something underlying, where if you go after that problem, maybe it will ameliorate it, but they probably still will need some management strategies. But there certainly is a lot that can influence this. But really our focus today is going to be on primary hyperhidrosis. And this is literally taken from the 2004 paper that proposed the diagnostic criteria. And just across the spectrum of dermatology, this is kind of what we're seeing more and more. There's not just one thing that defines the disease. You're seeing a compilation of essential features. You can have a couple of these things, maybe less important things. And I think that's going to be true for all diseases. So I guess this was a little bit ahead of its time. But in essence, there were essential things that define this. So things like it being, symmetric, bilateral, having a psychological impact on job selection and performance. But then there are a couple other things beyond that. Obviously part of this is the duration that should be at least for 6 months and not longer. And most of the patients you'll see will probably have it for a long time. They may not have picked up on it that they had it, but that's where diving in is important. And then 2 or more of the following to really clinch that diagnosis. Now, the problem here is there is a little bit of a contradiction in that in the paragraph above, that bilateral symmetric nature is a requisite, but then it appears again in the optional, 2 or more. And so that gets a little confusing because, we're really trying to distinguish this from secondary things. So I think that is problematic. The problem is that we haven't really talked about it. We haven't really thought about how that can be perceived or how that can influence the way we diagnose these patients. And this has certainly been perpetuated by anyone, all of us, in the hyperhidrosis literature, academic activities, conferences, in publications. It keeps coming up. I'm definitely part of that problem. This was from a program we did I'm going to say a week or 2 ago, because we looked at the same, right? The date on that is not there. But, this keeps coming up in terms of this is the essential things, and then these are the optional elements that you can select. So this is an opportunity not to say, oh, God, what were we thinking? But rather, okay, well, maybe there's an opportunity to update these criteria. So we really need to truly have clear guidance on how to define primary hyperhidrosis. And I really do believe that bilateral symmetric nature is required. It is a primary element of those diagnostic criteria. I think we need to remove that kind of optional component to it. And if we look at the kind of workflow, especially from a clinical trial perspective, I think that this doesn't have to be complicated. I think we can set this up very easily in terms of using those necessary criteria to define the disease and then kind of go down the kind of pathways to get those optional things as well. But I would like to make some recommendations in terms of how we can maybe better optimize this. Because for me personally, and I'd love to hear from others, I think that the cessation when one goes to sleep is central to that diagnosis of primary hyperhidrosis. I mean, my residents, so I ask every patient of it. Now, you have to be clear, because if, let's say, this person loves to bump up the heat and they wrap themselves in covers like my son and literally sweats through his blanket every night, that lunatic. Yeah, of course, you're still going to have it, but it's really in the setting of, that it should be normal sweating during sleeping or not, a confounding factor that really stops it. But to me, I think that's actually really, really important. And then I think the age of onset, I think this does start early in life. And I think that needs to be highlighted further. And we need probably to have some assistance in how to probe for that as well. So I think in general, we have to wait a very long time for diagnostic criteria to be updated. We see that with AAD all the time, but I think there's a unique opportunity to really set the record straight and help guide the diagnosis of this condition. Thank you. I will very rapidly turn it over to Dr.
All right, well, thank you so much, Dr. Friedman, for that great discussion about differentiating primary from secondary hyperhidrosis. And we're going to talk now a little bit about the patient impact, because that's really why we're here today. How is it affecting our patients? How is it affecting their lives? So I'd like to start in a moment with a video, and I think I echo what Dr. Friedman said. You know, patients, when you speak with them, will tell you this is ruining their life. They can't go out. They're terribly embarrassed. It's affecting their social life, you know, their job professions, their hobbies. And so what I wanted to do is just share with you a video of a patient talking about the impact of hyperhidrosis on her life. We probably won't listen to the whole thing, but I just wanted to share this.
My symptoms are excessive sweating hands and feet. My hands could be clammy to dripping sweat within 60 seconds or less. So it's something you don't talk about, it's something you keep secret, and you kind of just live inside your own world. I don't know how my hyperhidrosis is going to affect me, if I'm going to get embarrassed by it on a daily basis or have some physical limitation.
When I first saw Karen's hand dripping, that's when I first learned really what hyperhidrosis was about. I remember her like not really wanting to hold hands. And it's like, it's fine. It's like, I'm here for you. Like nothing's gonna change between us. It's fine.
So when I was in elementary school, that's when I started to notice that something was a little different with me. I would be in class and we would have to have a buddy system to walk through the halls, and you were expected to hold hands with your buddy, and no one wanted to hold my hand. And I didn't understand why. I had a very difficult elementary school year. I feel like I cried every single day from at least first grade to third grade, you know? I didn't know it was a medical condition. I just was like, oh, maybe I am gross. I don't know. Then I would ask my mom, like, what's wrong with me? I didn't know anything was wrong with me. I was in middle school when I found out what it even was.
I was hurting for her living through middle school. What if I never get a boyfriend because they don't want to hold my hand? What if I never get married? I think at that moment, it became more real. Like this could definitely impact her moving forward emotionally. So it wasn't like a cringeworthy, it was just like break your heart kind of moments, and knowing that I couldn't change it for her.
I'm a professional flutist, and playing my flute it's so challenging, and it's an obstacle I face every day. It's hard to hold onto the instrument. Many times I feel like I'm breaking my instrument just by holding it. My flute has been rusting and had to take it to the store to get it fixed often. And it also it tarnishes the instrument, I bought a brand new flute and all of a sudden it's like an antique. And people ask me, oh, is that an antique? I'm like, no, it's new. My sweat just discolored it. It just definitely feels like I can't play it to its potential and to my potential.
Pause it there, but if you'd like to see the rest of the story, it's on the International Hyperhidrosis website. But I think, you know, through the patient's lens, we can really see the impact on every daily activity and choice. And I think it really brings home how important this condition can be for a patient's life. So I also want to share a story. Dr. Khanna and I think she's here today, saw this patient in clinic at the VA about a month ago. And as I was preparing this talk, I was like, this will be really perfect, because I think we hear this all the time, But sometimes we're so rushed through the visit, we're trying to, figure out what we want to treat the patient with or, move on to the next patient. But this was a young female veteran in her 40s, and she reported really significant sweating since a young age. And we're hearing that over and over that, hyperhidrosis typically starts in adolescence. And this patient said she really sweat, particularly in her hands and feet and underarms and face, but sort of also had generalized hyperhidrosis. And she said, I have a closet full of beautiful clothes, but all I wear every day are these sweatpants. I'm so nervous to sweat through everything. I'm so embarrassed. I don't go out. I don't see my friends. I just stay home all the time. She was working as a home health aide for her aunt and shared with us she was really worried because her hands were so sweaty that she would have dropped her aunt when caring for her. And she really wasn't aware that there was any treatment for this condition or that we could help her at all. And she was so delighted to hear that we could offer some treatment. She also, and we'll talk about this later, there's some secondary issues that come with excessive sweating. She reported terrible tinea pedis of her feet that she could not control due to the sweating. So Dr. Friedman will be discussing that later, but it's not just the sweating. There's a lot of secondary skin issues that come along with this that we need to be aware of as well. So Dr. Friedman touched on this already, but really some recent studies show that nearly 5% of the US population suffers from hyperhidrosis, which amounts to about 15 million people. And interestingly, in other countries, it's much higher. In fact, in Japan, it's closer to 12 to 14% of the population in large surveys. And so I think it's probably underreported here in the US. About 93% of all cases are primary hyperhidrosis. As Dr. Friedman also shared, I remember my husband who, when he was a teenager, had hyperthyroidism and Graves' disease, and he was one of those cases of secondary hyperhidrosis. He was, it was the middle of December, and he was sweating. Everybody else was like bundled up, and he was, 100 pounds and sweating through everything. They're like, I think there's a problem. We might need to get your thyroid checked. But by and large, the majority is primary hyperhidrosis that we see. And in terms of onset, we discussed a little bit, it's often in that adolescent phase and early adult phase. But as we get older, hyperhidrosis usually decreases with age, the prevalence. So it's not as much an issue for our 60+ patients. And if you do see it arise in adulthood, you want to look for potentially other causes or etiologies. In terms of the genetic link for hyperhidrosis, I think this is really interesting in an area we probably need further data. It does seem to have a genetic link. Up to 65% of cases show a positive family history, especially patients that have Palmar plantar onset and patients who have it occur at an earlier age. And although there's some chromosomes that may be associated, certainly further data is needed, but it is something to ask your patients about when discussing hyperhidrosis. And one of the scales you'll see in a lot of studies and surveys, just so you're aware, is the Simple Hyperhidrosis Disease Severity Scale, 1 to 4. And patients with 3 or 4 note that sweating really interferes with their daily activities. And those have more severe disease, whereas 1 and 2 are certainly either don't have it or it's mild. But I wanted to share this scale with you because you're going to see it over and over in studies looking at hyperhidrosis. And this is a very easy scale to use when talking with your patients. Most patients have hyperhidrosis in the underarms. That's the #1 site, followed by the head and face. But you can see that all areas can be affected. But I think that's important to know when discussing with your patients. And you'll see here only about 50% of patients discuss this with a healthcare professional. So there's a lot of patients out there that are not bringing it up. And it's really our job, as Dr. Friedman mentioned, perhaps you're doing a skin check. Or my experience has often been on the way out the door, the patient's like, oh, by the way, do you have something for sweating? They're so embarrassed to bring it up. So I think we need to work on the stigma of that. And in terms of exploring the impact, it really impacts all areas of a patient's life, as you can see here. This was a study that looked at, the impact. And most patients, about 3/4 say it impacts their social life, their sense of well-being, their emotional health. So all arenas of their life are affected by this. And also, as Dr. Friedman said, the quality of life for hyperhidrosis is felt, as great as an impact as many of the other dermatologic diseases that we treat, such as psoriasis, eczema, and acne. And so it really deserves our attention as much as many of these other diseases do, that may be more visible in many ways, but again, this has a huge impact on patients' quality of life. This is a summary, and again, we've heard from the patient earlier, but there's a lot of different areas that it affects in terms of a patient's life, whether it's their professional life, their mental, psychological life, their social life, and certainly general lifestyle. In terms of the psychological impact, most patients with hyperhidrosis report some degree of depression and anxiety, so it's much higher than the general population. And unfortunately, that's this vicious cycle where a patient is anxious, perhaps, and then they get into a social situation and their sweating actually worsens. And so, it creates this vicious cycle of sweat and stress. In terms of the social impact, as we heard from the patient, intimacy, relationships, all of that is affected. Even holding hands in the school line, as she mentioned, can be impacted. So 3/4 of patients certainly report impairment in their social life. And it's a really time-consuming illness. We hear about that with psoriasis, with flaking and eczema, the amount of time patients are spending tending to their skin, but hyperhidrosis as well. Patients are bathing multiple times a day. They're changing their clothes multiple times a day. So really there is also an impact in terms of what they spend their time on and how they have to care for their body. And the physical impact is important too. I was surprised to hear that patient was a flute player because that requires a lot of manual dexterity and hands. But a lot of patients report that they can't work in electronics because they can actually shock themselves. Or, they can't work in certain jobs where their grip strength may be affected, for instance, if they have Palmar hyperhidrosis. So a lot of different, both hobbies and professional decisions are impacted by hyperhidrosis. And we'll talk later about the medical impact, but we don't want to forget that a lot of secondary infections and dermatologic issues can occur because with that excessive sweat and moisture, sometimes the skin barrier is disrupted. And so you can see both viral, bacterial, and fungal infections increase in the patients with hyperhidrosis, as Dr. Friedman and I will discuss later. So again, only about 50% of patients discuss this with a healthcare provider. There's a huge stigma associated with sweat. And so we have to really help our patients realize that this is a medical condition and that treatment exists. And more than 50% of patients say they would pay anything to stop sweating. So they're highly motivated for treatment. And yes, if we offer treatments, if we treat patients with hyperhidrosis, the quality of life improves. So we can definitely make a difference in their lives by offering treatment. So our role as healthcare providers is really to ask our patients about symptoms, to reduce the barrier and stigma, and offer options. And I think after today, you're going to feel very confident doing that and caring for these patients. So thank you so much, and I'll pass it on to Act 2.
All right, it is a pleasure to be here for the second time. This is great. Let's see, do I just... This one?
Or the arrows.
Or the arrows, thank you. All right. So we're going to talk about botulinum toxins for treating hyperhidrosis. And you've heard this, that, there's a female predominance, the patients that come into the office. Probably it's actually about 50-50 in terms of who has it, but you'll probably see more. And as you saw, underarms, is still the #1. And that's where botulinum toxins are FDA approved. And it's only the Botox brand, Onabot, is the only toxin that is FDA approved to treat hyperhidrosis, and it's only approved for the axilla. You can use other toxins off-label, and you can use toxins in other body parts off-label, but the only approved is the axilla. So remember where the eccrine gland is, right? So it sits deep into the fat and dermal junction. So that's where you're going to need to do your injections. The number of glands by body parts varies significantly. But that doesn't seem to change the dose quite as much as you might think. So the effect of the toxin by inhibiting acetylcholine will happen no matter where you're injecting it. So again, this is such an important tool, and we always ask this before and then after treatment, because sometimes patients forget where they started from, and they may say, "Oh, I didn't think this worked as well as I was hoping," whereas maybe at the beginning before treatment they were a 4, and then after treatment they were a 1 or a 2. So this is a really helpful tool. And the goal is not to get them 100% dry all the time. Well, it can be a goal, but we're not going to achieve it. And so the idea is to make them better. So sometimes a 2 or a 1. So how are you going to do this? Usually the FDA approved on label is 4 cc's of saline, unpreserved. Clinically, all of us use preserved, which is off-label, per 100 units. It's a deep intradermal sub-Q injection, and you want to put somewhere around 2 to 3 units per 1 centimeter. And the way that the studies were done actually was people were divided into either placebo group, 50 units per underarm, or 75 units per underarm. And they had to achieve a 2-point difference in that HDSS, as well as an improvement in their gravimetric sweat measurement. And you can see here, there's no significant difference between the 50 units per underarm or the 75 units per underarm in terms of the efficacy, or there was no difference in the duration. So therefore, the FDA-approved dosage is 100 units per treatment, or 50 per axilla. Other things that can be used is this one. No, this is Botox still, sorry. So you can see here the improvement in terms of the duration. No significant difference in the duration. Side effects are pretty minimal. There's a little bit of discomfort. It's a 30 or 32 gauge needle, whatever you want to use, so not too bad. Sometimes you can get some bruising. And then in the clinical trials, there was some reporting of compensatory sweating, although it was never measured. And it's hard to know if that really happens, or it's just that once the underarms are controlled, now they realize how bad their hands are, how bad the groin sweating is. So it's a little hard to understand if this is a true compensatory sweating, but my belief is that it's probably not, and it's just that they're noticing other areas. And when you look at least a 75% reduction of the sweating, you can see, again, a significant number reached that point in the studies, the clinical trials, and there was no statistical difference between the 50 units per axilla or the 75 units per axilla. And you can see the p-value compared to the placebo. As Mary talked about, a significant improvement in the quality of life, and I just threw up a couple of these. This is their ability to perform their work activities, significantly improved. And this is how you do it.
Paint the affected area with iodine. Swab at least a couple of centimeters beyond what you think you need to cover to help ensure you don't miss any of the affected area. Let the iodine dry. Apply a light, even coating of starch powder, such as plain cornstarch, over the entire area. The affected area will develop a dark blue-black color over approximately 10 minutes, indicating a positive starch iodine test. Using a surgical marker, draw a circle around the blue-black area, then clean the area inside the circle with an alcohol swab and let it dry. With the surgical marker and a ruler, mark the injection sites. To maximize coverage of the affected area, place the marks 1 to 2 centimeters apart. Make sure they are staggered and evenly spaced to allow for the medication's 2 centimeter ring of effect. Count the number of marks to determine the amount of Botox to be injected at each site. Most patients receive 10 to 15 injections in each affected area. The recommended dose is 50 units of Botox per underarm. Now you're ready for the injection procedure.
One of the keys is to dry the underarm really well before you do the starch iodine. And I always do a starch iodine the first time that I see the patients. And I'll show you why. So these are some different starch iodine results of my patients. And so if I didn't do this, I wouldn't necessarily know where to treat them. And I usually then just take a photograph, keep it in their chart so that I know. Now, if they don't have a positive starch iodine when they come into the office for treatment, you can treat the hair-bearing area, and you're probably going to get it right most of the time. So some people will just treat the hair-bearing area the first time and not do a starch iodine, and that's certainly okay. I always want to give them that most optimal result I can. And so some people will have a very tiny little area like this first person. And so I want to concentrate all 50 units right there. You know, the person in the middle, I'm probably guessing that they're going to need more than 50 units. That's a gigantic underarm. But I usually do start with the 50, and then if they don't get a duration or a control that's satisfactory, then I'll go up on the dose. And then you see this other one that's kind of geometric in shape. So I find that it's very helpful. So this is a positive starch iodine. The second one is a false positive. And so it's where the person didn't dry the skin well enough. And so you see a little moisture and it's just kind of smudgy on top. That is not a positive. So you need to just redo it and start all over again if you're going to rely on that. So again, if the starch iodine is negative and you're doing that, then just treat the hair-bearing area. And I inform the patient, today you're not sweating. I'm going to treat you where I think I need to treat you. But if it's not right, come back and we'll need to do it, a starch iodine and see where we need to add some more. And that usually happens within about 2 weeks. So let's take this one. So this one, there's no sound. Okay, I'd asked for no sound on all of them. So it's 50 units of Onabot per axilla. I'm sorry that says ABO. 4 cc's, as I mentioned, and just at that sub-Q dermal injection. And so around 10 to 15. So the idea is not how many units you're putting into each injection. The idea is you have an area and you need to divide those 50 units up. And I don't take all the time to mark and measure and everything like that. This is just for purposes of demonstration. So about every 1.5 centimeters apart. And honestly, this is very comfortable. Patients may be concerned. If someone's just a little panicked and they want some topical numbing, you need to do, if you're going to do a starch iodine, you need to do the starch iodine test and at least mark it out before you put on topical lidocaine, because you won't see that afterwards. So here's just to show that. And again, most of us are using 4 cc's so that you get a little better diffusion and into the axilla, and so you don't have to do as many injections. And again, I start with 50 units per axilla. If they're not getting at least around 4 to 5, 6 months, because the duration should be around about 6 months, then I'll go up to 100 units per axilla. Why 100? Because the vials come in hundreds, usually in 200s or 50s, so I just like to go all the way up. So what happens when the patient calls you and says it didn't work? Well, this stuff works, so you need to have them come back. And this is my first patient. You can see back in 2003. This was before there was insurance coverage, and she called me and she said, Dr. GLASER, I paid all this money and I am still sweating. I'm like, that's impossible, come back in. And you can see that I missed one little spot. So I put in about 5 units there and it's done. Here's another one, again, where maybe I missed it, maybe it just didn't diffuse in the way that I thought, but probably it was me. So if they're still sweating, have them come back and repeat a starch iodine and see if there's just a spot that's missing. Because that sweat will go over the entire axilla. So to them, the entire axilla feels wet, right? So what about other treatments? Well, like I said, they all work. They're all off-label. This is a study that was published many years ago looking at abobotulinum, or the brand name is Dysport, using gravimetrics. And again, you can see that 6 months and good results. So that's also an option. Incobot or Xeomin has also been published. And this one they were looking at trying to reduce the number of injections. I think you could do that. I personally am just in the habit of doing that every 1.5 to 2 centimeters, and it goes very quickly, and I don't feel like I need to do just 1 or 2 injections, but there are different ways to do it, and you can try those out on for yourself. So again, for me at least, optimizing the outcomes for the patients is to identify and record the severity before I treat them and then after treatment. Monitor with each visit, identify that area. I like doing a starch iodine at least once. If they're not sweating, again, I identify that in the chart that they weren't sweating when I did that first treatment. Sub-Q dermal injections. Results really should be seen within about 2 weeks. And then the loss of effect will start somewhere typically around 4 months. You need to let the patient know that. And they'll panic the very first time they're starting to feel moist again, but let them know that it's not like a faucet that you just turn right on. It's going to take a couple of months for it to get all the way back to baseline. And that gives you time, if their insurance is covering it, to go ahead and get that going and get them into the office. And if they're not getting adequate control, then consider dose escalation. So I'll stop there. And I guess, do you want to do questions at the end of all the talks? Yeah. Okay, perfect. So I think the next person is Dr. Passer.
If you say so.
Yeah.
Good morning again, everyone, and thanks for almost filling the room. It's quite nice to see this many people here that are interested in it. Don't get scared about these injections. You're going to be able to see them and actually do them this afternoon on patients. So I'm going to talk about another modality of treatment specifically for axillary sweating. And this is the something called microwave thermolysis. This is a device technique which does produce some almost permanent results in this of the sweating. The way it works is there is a microwave device which delivers its microwave energy to that deep dermis subcu area that you saw, with a cooling device on the surface. So you don't burn the skin if it's done correctly, but you do burn, if you will, the sweat glands and the subcutaneous fat and whatever other things that are in there, namely hair follicles and apocrine glands, which we'll also talk about. So the device is FDA cleared. When they say produces permanent, it does produce a longer standing result than anything else, and there is the anticipation that it will actually be a permanent improvement. And histologic studies have shown that those glands that are destroyed by these microwaves don't regenerate. So just think about if you put a piece of chicken fat in your microwave oven and turn it on, what it does, it fizzles and fries. And that's what we're doing to people's underarms. So if you want to say it that way, it always talks about it out on the street. All right, so again, you have the cooling in the top, the energy delivered where you need it. Here's the thing about the anesthesia. Originally, when we first started doing this, we just did multiple sub-Q injections of lidocaine, because it has to be done under anesthesia. But what we've learned is that if we do a tumescent technique of anesthesia, where we blow up the skin, the area below the skin, between the skin and those nasty little nerves and blood vessels that are in the underarm, we have more room to work with. And we can use higher microwave energy and get a better result. So almost everyone now does this high volume or tumescent anesthesia when doing this. So if you look at the original clinical studies, the amount of people who got sweat reduction, the 82% sweat reduction, that's reasonable for this. And that's what I tell patients. You're going to have this done. You will not be dry, but you will probably reduce your sweat by 82%. And that is good enough in this particular study, where most of the patients, all the patients, were really not said they weren't bothered. Now, another advantage of this technique, which is not really seen in any of the other treatments that we have for hyperhidrosis, is that it reduces underarm odor. Well, why does it do that? Well, because there's those nasty apocrine glands there, which it also destroys. So it is FDA cleared, actually, for odor reduction. In fact, it's the only thing that I'm aware of that actually is for that. I just will parenthetically say that most people who come in and their complaint is, I stink, actually really don't stink. It's fear of stink. But those who really do, it does reduce the odor. What else is down in there in that area? Well, the hair follicles, and it actually does reduce hair growth too. So it's important to inform patients that reduction of axillary hair is a likely outcome of a good mirror-dry treatment or two. Some people do need a second treatment. I haven't had any women complain about that, but I have had some men complain. They don't want to reduce their axillary hair. That is considered masculine. So, and laser hair removal and other things using other lasers are much more effective, but this is a factor. Okay, this is not a totally innocuous procedure. There are side effects and there are interactions that can occur with this. There's always some degree of swelling, some degree of postoperative pain, soreness, and tenderness. And numbness and tingling can result in the area for a long time, but almost always that does resolve. Now, there was just very recently in the October JAD, it was. Yeah, the October JAD, a summary of 502 adverse events reported spontaneously to the FDA system over the 10-year period of 2013 to 2022. Now, some of these were the years when the tumescent anesthesia wasn't being done, so some of these adverse events may be related to that. Surprisingly, infection was the number one cause, the number one adverse event recorded, along with neuropathy, nerve damage, and you can see burns, ulcerations, and erosions. That does occur, particularly if the cooling system is not working exactly properly on the machine. You have to be really sure that it is working. We want to highlight the issue of HS, hidradenitis suppurativa, and the use of mirror drug. It might be intuitive that this should work for HS because you're destroying some of those sweat glands and amacrine glands, and that's part of the problem with HS. The problem is that it actually makes HS worse. And a clinical trial that was really started for that, it didn't turn out to be. I personally have had 2 patients who had no history of HS who developed what I couldn't call anything but HS after mirror dry treatments. One was mild and resolved, the other was an ongoing issue. So don't do it in a patient who you think may have HS or who may have any kind of pathology, skin pathology, folliculitis, acneiform eruptions, or axilla. So again, to summarize, this is microwave thermolysis is a valuable alternative to treatment. It's a device which requires some sophistication and training in doing it in the formation of the procedure. It's FDA approved not only for the reduction of the sweat, but for axillary hair and odor. I'll again make the point that if you're going to do it, learn how to do the tumescent anesthesia. We are going to have a mirror dry microwave thermolysis device here for you to look at this afternoon, but we're not going to actually do a treatment. We can answer as many questions as possible. All right, so what else can we do for those pesky underarms?
So there are other things that you can use. I don't think they're used as commonly now as they used to be before we had the microwave, we had the botulinum toxins. But I just wanted to go through some of these so that you have an understanding that in your office you could use other things. Surgical removal is still done in some parts of the country, of the world, I should say. Liposuction can be done. All kinds of lasers and ultrasound RF devices have been tried. And anything that just injures the sweat gland by whatever method, if you've got an idea, it would probably work in the axilla. Most of these are limited to the axilla and not to other areas, focal areas of hyperhidrosis. So originally, about 40 years ago, they used to just remove the entire axilla. And the problem was it worked great, but there were contractions. People had limited range of motions of their extremities. And so techniques to try to reduce the size of the excision were studied. And this is probably one of the more clever ones where a little wedge is taken out or elliptical in the center, and then you flip back the skin and you take some scissors and you just try to defat, right? Because the eccrine glands are typically in the fat. So you defat the axilla and then you've got a tiny little line. And this article that was published for this study, showed that about 65% reduction in sweat. So if there's that time that you just don't have the device and the patient, you can't get botulinum toxin and all these other obstacles are in your way, just think and you can come up with some other way to treat. Liposuction has been used for a long time. Again, liposuction is at the level of the fat, so again, that makes sense. This is one study where they did follow up the patients for up to 7 years. There were only 10 of the patients. 4 had relapses. Complications were pretty mild. And I used to do a lot of liposuction prior to the invention or the use of botulinum toxin. What we did know is that the more aggressive you get with the liposuction cannulas have different types of numbers of ports that you are using, whether they're rough, whether they have little rates on them. But when you use a more aggressive cannula, as you can see, like figure C has these little barbs on it to really rasp that fat on the dermis, you get better results, but you also get more side effects. And so that's the problem. So when you get to that cannula with the C, you're starting to see better improvement, but more side effects with hematomas and some scar and dysesthesia and things like that. But this is one of my patients that, I was doing liposuction on using tumescent anesthesia. I did a starch iodine to identify where I needed to be. You put in the tumescent fluid here, and then I will take my cannula and I would first suction with the cannula ports down and then rasping right against that skin. And you can see how that dermis is getting pulled down into there and really getting that. And you know what? It helps. It helps a lot, but it definitely didn't meet the same outcomes that botulinum toxin injections do or the newer treatments. So, this is what we did in the late 1900s and 1900s. Late 1900s. Yeah, I really look good for my age, just so you know. This is what we did in the late 1990s and early 2000s. And so after botulinum toxins came out, several of those patients who were, quote, satisfied at that time, once something better came out and had me treat them with that. Lots of different lasers and devices have been tried, not only through on top of the skin, but actually placed inside the skin. And again, if you have these devices and it's something that is there for you, you could try them. But I do think today we have better treatments. This is with an ultrasound assisted liposuction, also showing that works because you're getting that energy and that heat as well as trying to suction out as many of those glands. And that also, in that study, showed a decrease in odor. So I think when you're destroying glands by whatever method, you also are probably going to get some odor improvement. And just having a dry axilla is probably going to reduce some of that bacteria that acts on the apocrine secretions. So patients may tell you with all kinds of treatments that they've noticed an improvement in their odor. Since some of the devices like the microwave reduces hair and reduces sweat, somebody decided, well, let's try the hair removal lasers and see if we can reduce the sweat that way. And it really didn't work so well, but it reduces the hair, so that's still good. And then RF, again, anything that's going to get down, produce heat, and anything that especially targets water. That's why the microwave works so well, right? Because microwave heats up water basically better than dry items. So you can use these kinds of devices to improve sweating. So you just sort of have to use your imagination and what you know about it. So in summary, there are different surgical techniques, lipo devices that can reduce sweating, but there are other options that you'll learn more about this afternoon and this morning as well. And most of these are really only applicable for axillary hyperhidrosis. So with that, I'm going to pass it along to my good friend David again, also in the 1900s now.
Sorry to feel my age when it's that. Okay, well, there's something that is brand new. You have never heard of this before. It was just FDA cleared within the very recent past, and it's not really marketed yet. But it's a really great and neat idea, which I think is going to become part of our armamentarium for treatment of axillary hyperhidrosis only at this point, perhaps other areas later on. And this is the targeted alkali thermolysis. Okay, so you already heard that the microwaves excite the water molecules and make heat. Well, we can excite those water molecules to make heat in another way. And that's with using a metal. What metal is that? Well, it's elemental sodium. And elemental sodium in this patch, which is placed on the underarm, goes to where the water is, and where the water is, an exothermic reaction occurs and it makes heat. And so it destroys the sweat glands. Now, if you have sweat on the surface of the skin, that's no good. It's going to make the heat there and destroy the surface. But when you get it, if it gets where it wants to be, there is a thermolysis of the sweat glands. This is an old picture of an older part of the device, and it looks a little different now than the commercial ones. But it's a single disposable one-use device. The sodium is in on a sticky backing that sticks to the skin. It's applied to the dry axilla. It has to be perfectly dry, and the patient needs to sweat a little during the treatment so that there will be some water for the sodium to react with, and it does work. In the clinical trials, to tell you briefly about the pivotal trial, which Dr. Blakers and I both participated in, patients, it was a placebo-controlled trial, 1-to-1. The patch was applied for up to 3 minutes only. It's removed sooner if the patient feels any burning, because you obviously don't want to get that thermolysis on the skin surface. You want to get that in the glands where they are. In our clinical practice, I've had some patients who can only leave it on 45 seconds. Others at the end of 3 minutes say, yeah, I don't feel anything. So maybe in those people we could go longer, but 3 minutes is the result. Basically on the Fitzpatrick skin type, there was an array of those in the trial. The HDSS patients who started were mostly grades 3 and 4, and they had gravimetric sweating that met their 50 milligrams per 5 mLs, which is the standard gravimetric measurement for time. So the primary endpoint was the people who got a grade 1 or 2 improvement in the HDSS. That was the same endpoint that the microwave thermolysis, the microwave one, had to do. And then we looked at some secondary endpoints as well. And I'll just show you the primary endpoint patch was achieved by 2/3 of the patients. So that means 1/3 of them didn't get the primary endpoint. They didn't get the 1 grade improvement, but they may have gotten some. Look at those who did get 3-point improvement. A few did who used the patch. 1/3 or so of the patients got the 2-point improvement, and more than 1/3 got the 1 point. So that's the patch. It lasted 16 weeks in a little under half of the patients who used it. So there are some adverse events associated with this. Skin irritation and burning can occur, and if during the treatment there is any burning at all, the patch should be immediately removed. The axilla flushed to remove any of the sodium that's still on the skin. And there are really no other AEs to consider, except there was some non-axillary AEs, but they really weren't related to the treatment. Most were mild to moderate of those and easily managed. So this patch is something which I think is going to be part of our treatment armamentarium. Low risk treatment. It's not very expensive. It's provided, applied by the provider in the office or clinic. It's not something that patients can use by themselves, and there are minimal safety concerns. So we have now finished talking about really the primary treatments for axillary hyperhidrosis. And we're going to go on now to talk about other treatments which can be used on the axilla, but also elsewhere. And I'm going to start with aluminum-based topical agents, over-the-counter and treatment. I always show this picture. It's a little old now. You all see these people who are sweating. You know who the woman in the upper right is. You know who that is. That's Margaret Thatcher, the former Prime Minister of Great Britain. The one on the left, all the way on the left, is Angela Merkel, the former Chancellor of Germany. It doesn't look really nice when you're the head of a major country and you're walking down the red carpet in formal dress and you have a sweat ring under your arm. It's just really not nice. The middle guy, you know who he is. If you're very interested, go to celebritysweating.com and you can see videos of your favorite person, as well as celebrity, sweating under their armpits. Now, just the fact that there is such a site really tells you that this is something that everybody is really interested in, but don't really want to talk about. Okay, and this guy we all know who he is. All right. No one in this room was born before 1960, but I just will make the point that in the 1960 presidential debates, the first presidential debates that were ever televised, Richard Nixon versus Kennedy. Kennedy wore makeup, Nixon refused. Nixon was constantly wiping his face. He had hyperhidrosis. So obviously, hyperhidrosis affected the choice of people for the president of the United States in 1960. Okay, well now, I don't really know if actually most of those people had hyperhidrosis, but these people do. And you already saw a picture of sweat dripping off the hand. The upper right, a student who's trying to write, getting it smeared. The lower left, sliding out of your flip-flops or your sandals. And the lower right is the common one that we see all the time. Selling antiperspirants and deodorants is a big deal. Now, how many of you know the difference between an antiperspirant and a deodorant? You know what the difference is? Okay, well, I'll get a few hands. Most people don't. Antiperspirants have active ingredients that control eccrine sweat. That's what they are. Antiperspirants have no active ingredients that control eccrine sweat, and they all they do is mask odor.
Deodorant.
Okay, it's odor.
Deodorant.
Deodorants, I'm sorry.
Yeah, that's okay.
You missed my dimension again.
You were just checking to make sure I was listening. No, it's okay.
Deodorants only have fragrances. Sometimes it's an absorbing fragrance, sometimes it's a nice fragrance. So let's say that you want to, well, let me finish about this, right? So the first deodorant was not marketed until 2003. But this one called Odor, oh no, was 1912. And advertising to convince women that they stink. And that was the basis for this whole industry. So Odor, oh no was this aluminum chloride paste. It's terrible. You put it on, it burns your underarm. The AMA called it fraudulent and dangerous. But it's the same active ingredient that we use. Here's some of those ads I heard earlier that I just picked out on. Talk about, you want to catch a man, you have to use this stuff. Dorothy Dix, who was a famous columnist everybody wrote to, advised people that hey, if you learn the first rule of charm, you have to have it. I mean, this is what it was. Have arm hormones. All right, well, now we've gone a long way from the Odorono and from the aluminum chloride paste to a vast variety of cosmetically elegant preparations designed mostly for the axilla. In fact, virtually all of the currently available over-the-counter antiperspirants are designed. Almost everybody uses it. So how many of you got up this morning and took a shower and put on your antiperspirant? You need to put an antiperspirant on at the time when you're sweating the least. So when is that? That's at night. You need to put your antiperspirant on before you go to bed. Well, I'm going to get up in the morning and take a shower. I'm going to wash this stuff off. It's not going to do anything. Well, you won't wash it off. I'm going to show you how antiperspirants work in a minute, but you don't wash off the effect in the morning. If you want to put on something to smell nice, then put a deodorant on in the morning. I got it right this time. So antiperspirant when you're sweating the least at night, deodorant in the morning. So here's how the antiperspirants work in a cartoon. Upper left, diagrammatic representation of the eccrine sweat duct and the skin surface. Middle upper middle, we put the antiperspirant on. The active ingredient are the red dots in the vehicle. The sweat in the upper right comes out. It dissolves the active ingredient. Lower left, it starts to make a chemical reaction. Middle and bottom right ending up in a salt. It's a physical plug that plugs the sweat glands. That's how antiperspirants work. And when the sweat glands are plugged, feedback mechanism, they don't sweat anymore. If they do, then you get miliary crystallina. Okay, so here are some of the over-the-counter products that you can get now that are aluminum-based, carefully masked out by our CME cops who have sanitized all of our lectures just because we're not allowed to talk about their names, as you know. When you look at these, there are so-called clinical strength or clinical protection or clinical something. And those antiperspirants work better than the ones that don't say that. So the way you know that, and you can tell your patients, first of all, it has the word clinical in the name. It comes in a box, which most of them don't. If you go to the drugstore where you buy your antiperspirants, deodorants, you'll see most of the things that don't come in a box. These do, and they cost about twice as much as the ones that don't come in the box, but they're worth it. All right, put it on at night before you go to bed, wash it off in the morning, and put your deodorant on if you like. Do not include aluminum chloride. In the commercial preparation of aluminum chloride hexahydrate, which is a dry salt that everybody uses, the instructions say to occlude it. It makes no sense to do that. You don't want to occlude it. You don't want to promote percutaneous penetration through a hydrated stratiform. You want it to go down the sweat gland, so do not occlude aluminum chloride. All right, I want to just completely dispel the rumor that patients have that aluminum chloride causes Alzheimer's disease, right? Because you will hear this from patients. It doesn't. And the reason why it's there is back in the 1960s, there was a study, an autopsy study that showed aluminum in the brains of Alzheimer's patients. That has been repeated many times. It's never been found again, but it's still out there. Aluminum chloride does not cause Alzheimer's disease. Aluminum chloride does not cause breast cancer. There are, again, out there in the world, the idea that, well, you're shaving your underarms, you're nicking the skin, you're putting this on, it's near the breast, it's going to get in the breast, you're going to cause breast cancer. No, says the American Cancer Society. No, says breastcancer.org. No, says the Susan Komen Foundation. No, says the National Cancer Institute. But people have this in their head. You need to take the time to explain this to people. And I do, briefly, but if they won't let go of it, then I say, okay, we're not going to use aluminum, and you're not going to convince you. I'd rather you use something that you're going to do. That's just to make the point about antiperspirant versus deodorant. Okay, so aluminum chloride, topical antiperspirants, and glycopyrronium cloth, which I'm going to talk to you in a minute, are first-line treatments for axillary hyperhidrosis as recommended by the International Hyperhidrosis Society. So let's go right into the aluminum chloride. There is one currently FDA approved. There's the glycopyrronium tosylate wipes, brand name Qbrexza. In the United States, it's Rapaport in Japan. There's some other topical anticholinergics in other countries of the world, but we have now, in terms of FDA approved and marketed products, we have the wipes are the only ones that we have. And they come in a little package, and you open the package and you take out the wipe, and a single wipe of the skin is what you do. One wipe of the underarm, take the same thing, and one wipe of the other thing, wash away your hands, wash, and throw it away. If you touch your eyes, your pupil dilates, and if you go to the ER, people think you have a stroke. Okay, I'm just very briefly on the clinical trial, the pivotal clinical trial of this. There were two clinical trials using the active versus the vehicle wipe. They used a different patient-reported outcome than the HDSS that you just heard about. And I will just parenthetically say that the HDSS, although useful clinically, and we're all used to it for many years, is not acceptable by the FDA for registration of a new product anymore. So this was a different PRO. I won't go into the details of it. The demographics of the patients in the study were those that we see in normal practice. If you look at the response rate of a 4-point improvement in this 10-point scale, the patients versus the active versus the placebo, there is a statistically significant and clinically meaningful difference in both the patient-reported outcome and in the gravimetric measurement of the sweat. I'm going to go through this. Looking at the treatment emergent adverse events and other things from this trial, most were moderate. And what are they? Well, look at this list, because you're going to see this list again and again and again when we talk about oral anticholinergics, when we talk about other topicals, which may be coming along. This is what it is. Dry mouth is the biggie. Now, I am not at all worried about people putting a topical anticholinergic on their skin and getting some dry mouth, because we give it to them orally all the time and get some dry mouth. That's the endpoint in titration for oral drugs, which you'll hear later. But this is the list from the study. Okay, so their conclusion was that this works and it's safe and it's effective, has statistically significance and clinical meaningful improvement. Then they did a long-term study. What happens after a year? Well, bottom line is the effect lasts for a year and no new adverse events occurred during the year. But look at where they were upper right-hand corner, the same ones that we said. Talk about mydriasis in a minute. That's the blur. Looking specifically at subpopulations, if people have more than one facial focal area, it can be used in others. Okay, I'm going to move on a little bit. Here, they didn't matter how old you were, what gender you were, what your fist type was, or what your BMI was. It still worked. Okay, a sub-analysis was done on the pediatric group because this drug is approved for patients 9 years and older. 9 years and older, which is really great because, as you just heard, that's when this often starts, and in that age group. And basically, when you look at on the left, the 2 bars on the left, and the kids, 2 bars on the right, the adults, they're almost exactly the same. In fact, the efficacy was almost the same. The placebo worked better in the adults. And if you look at the kinetics of the response, it really is no difference. So we feel comfortable using this in children as young as age 9, gravimetric and DLQI response both. No real difference in the adverse events. I'm going through this quickly. This was a list of the pediatric patients of all the patients who had adverse events, and they were all dry mouth, some of them had mydriasis. Now, if somebody has bilateral mydriasis as opposed to one side, either means they got it in both eyes, which is possible, or they got some sort of systemic absorption. That was not really noted in this one. All those were pretty mild, except the one 16-year-old at the bottom who decided if it was good to use one swipe under his underarm, he would just rub it all over his body, and he got he got everything, bilateral. This is my point about you don't want to see this. All right, in the study of the 31 patients who had mydriasis, it was specified as being unilateral for the 23 of them. They all resolved, and they all resolved without complications. That is a little scary. Okay, so this one shows you that that over time, there really weren't any more adverse events over time. So this is a safe and effective treatment to use. There are some local skin reactions, some erythema, some burning and stinging, all of which can be either managed by nothing or a little mild hydrocortisone cream if you need to. And the efficacy in the study maintained for 48 weeks if they continue to use it. It's a daily use treatment. Daily use treatment. One night. Okay, so we, the IHHS, recommend glycopyrin cloth along with antiperspirants as first-line treatments. They've been effective to those young people, but please have your patients wash their hands as soon as they have done the one wipe. Don't use it all over the body, and don't touch your eyes. Don't touch your eyes. All right, what about palms? Okay, we already heard that palms are as big, or if not bigger, problem than the axillary hyperhidrosis. Can you use this stuff on the palms? Well, I'm going to show you an open label cohort study of different application methods. You can put it on the palm. Well, how's it going to work there? The skin is much thicker. How long is it going to have to be on? Is occlusion going to be helpful? So we did a study of 120 patients with 4 different application methods of these age 9 or older. And basically what we did was we applied it. We covered the hands with either cotton gloves for 15, 30 minutes or overnight, or we covered the hands with occlusive nitrile type gloves for 30 minutes, and to see which worked best measured by PROs. We didn't do gravimetrics. This was all done during the pandemic. And if you look to see, the 15-minute under cotton gloves worked the least. The 30 minutes under cotton actually worked the best, better than occlusion. You would have thought occlusion might work better, but the problem is when you have a sweaty hand and you occlude it, what's going to happen? It sweats more, and it just washes all the drug out. So you can use this. You got too much dryness in some patients. But you can use it, put it on under cotton gloves, a non-occlusive. Why the cotton gloves? Well, really, it's the reminder that they have something on their hands so they don't touch their face or do something else. So I don't look at any of this except for the bottom line, looking at the total adverse events. And if you look at actually the 15-minute under cotton, which didn't work very well, didn't have much adverse events either. The overnight cotton had the most adverse events, and the occlusion versus the non-occlusion 30 minutes was about the same. All right, so you can use it for Palmar sweating. Put it on 30 minutes of non-occlusive cotton gloves. Don't wash your face. Now, wash your hands. Don't touch your face. Don't touch your face. Don't try to save it, by the way, for the next day. Don't try to cut it in half and get 2 days worth of applications out of it. All right, so there are other topical anticholinergic disorders that are under development, and we're going to talk about those later. All right, shifting another gears now to another procedural treatment. This one mostly for palms and soles, but can be used for an axillary as well. And we're going to have some hands-on, or I guess I should say hands-in demonstrations for you of this technique today. So what do you do for these feet? Okay, this is truly the agony of defeat. Slipping and sliding off the exam table, slipping and sliding out of your flip-flops. Can't wear sandals. Sweat beading on there. All right, so these are 2 of the older iontophoresis devices that we have used historically for years. Iontophoresis has been around even since I was born, believe it or not. I mean, that was when they had to hand crank the electricity. And it basically involves the passage of electric current through the skin. How does it work? Well, we're not really sure. Now, these are lists of devices that have been available historically. We have a new one that we're showing today called Dermatology, which I think you'll like, perhaps even better than some of these older ones. But there are different countries have different ones available, and we will show you the Dermadry one today. So here's some of the other ones. I like the electro-antiperspirant name. That's a cool name. There is the Dermadry, which is a newer version of it, by the way, which we're showing today. We don't really know how it works, but it probably works by the same way that the antiperspirants do, by depositing, plugging the sweat glands with those ions. And if you have somebody who's had Palmar hyperhidrosis, has had iontophoresis, and has worked, and you repeatedly tape strip an area of the skin, you can see sweating returning in the area that you tape strip, indicating that you're probably pulling out the plugs. So it really does probably work that way, but we don't really know. Traditionally, and there have been some side effects, adverse events from iontophoresis, stinging and tingling along the waterline, if you will demonstrate this for you this afternoon, or erythema, vesiculation if you overdo it. You can make iontophoresis work a little better sometimes by throwing some glycopyrrolate into the water and dissolving it, and using iontophoresis is used in other situations in medicine to drive medications into the skin, and maybe it works a little bit if you do this by putting glycopyrrolate in the iontophoresis trays. But we're not sure if that really is working topically or just systemically. We don't really know. Traditionally, the complications of iontophoresis have been what you see there. What does that mean about mental implants in the current path? Well, if you've got you're doing a foot and a hand, and somebody has a pacemaker, you don't want to have the current going through an area of the body where there's been some sort of metal implant. You might end up development in those areas. So the regimen for iontophoresis is using tap water, regular tap water out of the sink. If you're in an area where it's particularly soft water, that means no minerals in the water, you might want to throw a little bit of a teaspoon of baking soda or something in the water to add some ions there to breathe. If there are any little cuts or nicks, or somebody's been picking their fingernails or biting their cuticles, and you might want to cover that with just a little bit of petrolatum, so that because if you don't, those areas will sting a little more in the current. And we usually start the regimen of 2 to 3 days, 2 to 3 times a week until improvement has occurred, and then once weekly after that. We usually will have the patient come into our office, demonstrate the treatment, how to do it. It's not rocket science, but depending on which device you have, there's different ways there are different nuances about how to do it properly. These newer ones are much simpler and much more patient friendly. But we feel as though we really want to have the patients really have a hands-in experience to see if it's something that they're going to really want to do. Usually it takes a dozen or so treatments to get the best results. And you can there's no reason why you can't use a topical anticholinergic in addition to iontophoresis to help it work a little bit better. But I will tell you, really, the patients that I start off on iontophoresis, probably less than half really continuing. It's just a pain in the whatever you're doing, and as well as another body area. But you're not going to do this for a college kid who's in a dorm room. They're not going to do this. You're not going to do this for somebody who travels for work. You're not going to do this for somebody who doesn't have 20 minutes 3 times a week or won't develop it. You're not going to do it with a mom who's got kids to worry about. It's just not a practical treatment, but it's a great one. It happens to be the most cost-effective way to treat Palmar hyperhidrosis if you can get it to work. Okay, so it's highly dependent on which device you're using, how the patient is trained to do it, and the temperature of the water bath. You have to have some. Okay, so we are going to have a break right now. If anybody who wants to put their hands in an iontophoresis device can come up to the front here and see what it's like. And we have a couple of our staff here. Use the facility or do something else. Go on, anybody wants to use it.
First, you electrocute yourself.
Make sure you put a little bit of one-time thing, like scrub.
I mean, technically, like I don't know. It's like not a. We don't understand. So like, I remember like talking to like a couple of examples now I'm like you should just yes, take us into that. I don't even know what I am. I feel like no one will start thinking example description. I mean, I'm trying to yeah, you get that. Seriously, you get that.
And then it's not even
I do that with Therapy. You can't take a whole thing and I'm like, you take this on and you push it in. Take them out, my hair, and stuff. Just for example, like you're like no, it's crazy. I know, expectations are and like mostly interviewing
we're not having to worry about it. I filled it out. I didn't send it because I was like, you have to sit down. She was like, oh, it's fine. And I'm like, okay, so I'll leave.
I know a difference.
That was 12 years ago.
Well, they're all gonna be like, I'll go to like. I know.
I just have to say something.
She was going through thoughts, like cuddle up honestly, I just and I was like standing literally had no idea what to say. And he kept doing it, just like trying to be all like then she takes it to
dog knows what he's doing. Set the standards. So funny. No one ever worried about color.
That's what I'm saying. So like, I don't know what this is about. Is this
Like, here comes Mike.
Yeah, exactly.
In that medicine. Haggard. It's just like, I want to be. I mean, I've never thought of like Westport is my favorite.
But I don't know
It's
that.
just also like from my first home, they never had mental health recovery, never had I was like everything from med school, like that's why it's right there to be like, down in my backpack right now.
I should show you this.
I almost feel like mine's like literally balls up. Like shaking.
Stay in line.
That's a lot. They just buy
You look better. He was like, you look better in your photo.
I know that was like, I was thinking, I was like, I don't understand the
She has a green I just have
It wasn't great.
Should I be getting more? Whatever you need.
That was like,
Like happy to wear derm coat if there's like I
they did say
yeah. I can tell you the things like that.
I'll just call him back.
You still have that now? Okay.
They usually have
You have a last name?
no, because it was just a voicemail.
Where's he one? You know.
Well, they're located
I mean,
Can we sign off on all of them? I'll just look at the note.
okay.
What do you hear the hot tub?
Just get
And then,
Another section.
Yeah, of course.
Undertreated, maybe. Yeah, and it's not even as bad.
You started with that?
Use this for years and years. Don't take this is like in this just to have it. First time I sit
Just to show them how to do it. You can look on a video while you're doing it.
I mean, they have that relationship.
I don't know if they know. It looks very easy to do.
It absolutely should be. Not me.
My friend has doctor like
When I was working out, this was how it
There's no way to know.
I didn't see that movie there. I saw that, I was like. We all have to do
I can show them how to set it up. Yeah, because I did.
She was saying, it's a hardship. It's a hardship. First thing that goes in the plot, and then just stick it.
I was confused with everything. I was like,
Yeah, for this.
I just want to work to my teacher.
Probably or not, yeah. Especially have a lot of fishes.
Yeah, starting off. I don't know.
I'm very confident. But did you watch I feel the top three, I'm gonna scream. Like once here, once. Oh gosh, so good. My brain, I knew it was crazy, so I just said it.
I know, that's
We worked 2 days.
I was so fine.
Mondays.
Ended up with a patient was against
Probably will go. I'm gonna go like. Yeah. That's true. Yeah. Like Jared was saying he was somewhere that's being like we're not reading.
It's like we're getting there.
Guaranteed for 1 year or 2 years.
The hill I'll die on. Oh, I honestly like that. Because you go past it, it's getting solid.
That's like addition shock.
But then it's like you missed the like the surface tension of the water because you just saw it was also like
Hey, guys. So, everyone's attention. Thank you. So I think what we'll do is do a little of Q&A from the first series of lectures. That was a lot of information in a short amount of time. And obviously a lot of you had an opportunity to try out on the Iontophoresis. So I guess my first question is, what did everyone think? What is Iontophoresis? Anyone want to share their mind-blowing experience? Anyone? Maybe a more tailored question. What did it feel like? Like your hand was asleep.
Like tingling sensation, slight stinging after you increase the voltage to like 5 and above.
Okay. So hand asleep, tingling.
I didn't feel anything.
Didn't feel anything. I think just having that experience is going to make you much more efficient at telling a patient, if you're going to recommend this, what it's like. I mean, so often our patients ask, well, what are the side effects? What am I going to feel like on it? And so often we can't really give that information unless we ourselves are on that therapy. So I would argue with things like this or any opportunity to try things in a safe manner, it just arms you with more anecdotal experience to help improve adherence when patients are doing ongoing treatment, whether it be medications or devices. Any other feedback related to Iontophoresis?
I just want to say that some people are going to have more pain or discomfort than others. So don't, discount when someone says that for them it really hurt. Then you just need to cut down on the energy and let them start a little slower and make sure that they don't have little nicks or disruptions in the skin where the energy is going through. But doing this for, I've got a pretty big mouth. Can you guys hear me?
Yeah.
No, I don't need that.
Yes, you do.
I do, okay. You're taping it, that's why, I know. All right, sorry. So, if someone's really having discomfort, just tell them to lower the energy. But doing this for years and years with large audiences like this, we'll see people who at an energy level of 1 have significant, they can feel that tingle and stuff, and others are up to 8, 12, and they have no discomfort their very first time. So there really is a wide range.
And just be sure that if you have any little nicks or cuts in your hands or you've been picking your cuticles, that you put a little bit of petrol on it, because otherwise that's where the stinging and burning and you won't be getting the treatment out of it.
And no jewelry. Yeah. Yes.
So is the effectiveness different if somebody can only tolerate it at 4 versus 8?
Sometimes yes, but if they're really doing the frequency, I think they can still get some improvement. But I think it's more just the sensation. Do you think people, I think they can still get results.
I really don't have controlled observations about that. It would seem intuitive that if they didn't get the full 15 to 18 milliamps of current, that they might not get the best effect, but it's so variable anyway, it's hard to tell.
What is the minimum voltage that is desired for best effectiveness?
What's the minimal voltage?
I don't know.
I don't know. So there was somebody who chose an energy and it worked, and that then was the energy. That's how.
This system is, my understanding is it's preset for a certain level for the hands and for the feet and for the axilla at different levels. I guess those levels were decided based on what was a dose-finding study of some sort that proved that was most effective, at least adverse events. Is that correct?
But some people will have thicker feet, or calloused hands, so they may need to go higher. And then think of, telling a 6-year-old with very thin skin on their hands and feet, they may need to have. Do you have a pediatric setting? On that, there's no pediatric setting for it?
In the US, it's adult.
Oh, adult only, okay. So that's an off-label use, but they may need to go lower, yeah.
Anybody have any questions on the other topics? Either of these, we can tell you right now.
Just a general question of what we've discussed. So what, over everything we've discussed so far, what is actually covered by insurance for these patients?
minimal.
Really good question. So those
What's
people who
covered by
residents
insurance?
Work at the VA or in a military situation, it probably doesn't matter. You can get whatever you want to do. Botulinum toxins is sometimes covered for axillary areas by most, regular commercial health insurance if you work hard enough for it. Oftentimes, if it's used in other, off-label areas, which we'll hear about in the next talk, it's not. And it gets to be expensive. And that gets to be, so when you're evaluating any individual patient for what kind of treatment are they going to need and get, obviously, if you dangle a carrot in front of them and they can't get it, that's worse than not dangling the carrot. So if you know that their insurance isn't going to pay for it, there's no point in telling them, well, this would be a great treatment, but you're not worth it. Insurance companies not worth it. Iontophoresis is often covered. And usually, if I get a denial for iontophoresis, I'll try to make that a peer-to-peer contact with the medical director, and I'll say, well, iontophoresis, we're going to have to do Botox injections, and that's going to be way more expensive. And then he comes up, what's the name of the machine again? So it's saving expense. The topical anticholinergic, the glycopyrronium wipes are variably covered by insurance. But when we're treating our patients with hyperhidrosis in the treatment room in a private practice setting, it's not just us in the treatment room, the patient, the insurance companies in the treatment room too, and their view as important or more as what ours are.
I think to that point, how you document will play a very big role. So for example, with botulinum toxin injections, you typically need to fail a first-line therapy, which would be a clinical strength antiperspirant, and now at the same line would be glycopyrronium tosylate cloths. So, this is true for every disease. Always document what a patient has tried and failed, because they're going to go back to you at a minimum with that first. And then, of course, you can decide, are you going to do buy and bill, or you just put everything through insurance? There's more risk with buy and bill. But I think it goes down to documentation and make sure they do try everything, or at least you document that they tried certain things and failed them, and also document impact on quality of life.
We're going to talk more in detail about some of these insurance coverage later on this afternoon. But it's always bugged me a little bit when they say, well, you can't use that botulinum toxin on people's hands because it's off-label, it's not FDA approved. We want you to give them a 6-month trial of glycopyrrolate orally. Well, that's not approved either, Well, okay.
With the mirror dry and the worsening HS, is there thoughts on why that happens?
Well, I can give you, the question was with the microwave thermolysis and the HS, why does it worsen the HS, and what could be the mechanism? Well, when you're doing microwave thermolysis for treatment of sweat, you're producing some degree of scarring. I mean, that's what you're trying to do. And what is HS after all? In part, it's all that scarring. And so, that's a thought that I've had about why might that be the case. Maybe you're plugging some follicles, and that's contributing to the etiology of the HS. But HS is so multifactorial anyway, so you know what's the cause. That's a thought.
Are there some questions in here about the other treatments that, like Deanna talked about, injections for the underarm? So some questions on that? You'll be seeing a lot of
I
that
have a
this afternoon.
question.
Awesome.
That's okay. So often in dermatology, we are about combination. It's rare that we do just one thing. What is your kind of typical approach to combination therapy when you have a patient who's coming in, getting serial injections? And a kind of a side question to that is, I know we talk about every 6 months. That often is not the case. There are patients who need it every 3 or 4 months. And how do you address that in terms of access?
So I'll take the last question first. So if they're not getting in their axillary disease at least about 5 months, then I escalate the dose. And I usually don't get any pushback from the insurance companies if they're covering it for whatever reason. I like to do that more than giving it to them every 3 months. I like to increase the dose. But sometimes it's how I've prepped the patient ahead of time that you may start having a tiny bit of sweat in the first, in about 3 to 4 months, and then it'll gradually get a little bit worse because they're afraid when they feel that first sweat drop that it's just going to turn on. And usually they'll get at least another month beyond that. So I think that's a little bit easier, but I prefer dose escalation if I can. And then I also would check to make sure that they were completely dry, because they really should be. The only people that I've really had that are very dissatisfied with the microwave are those who got botulinum toxin treatment first, because that is just makes you so dry for months. I mean, it's just amazing. And Mirror Dry makes you much better, but it doesn't make you 100% dry. So, you know, it's like that patient who with psoriasis gets 100% clearance, and then their insurance makes you use a different drug, and then, you know, they're only 85% cleared. They're not happy with 85%, right? They were used to having 100%. So if you're switching a person from botulinum toxin to microwave, you just need to really stress what the expectation is so that they will be satisfied with that expected outcome, because it's not 100% like it is with the botulinum. So the combinations, we're going to talk about it soon, but first off, I'll tell you, I never use topical and oral anticholinergics together. I use one or the other. I want to know what the one is doing. I don't want to have to second guess if a side effect is from them touching their eye or whatever. The other thing that I wanted to say about the topical glycopyrrolate, the wipes, is ask if they have pets and make sure that if they have pets that the trash can is covered. We had one of my patients who the cat got in and then got the cat's pupils blue, and they took the cat to the vet, and anyway, it was just from the cat was getting into the trash can. So be sure to ask about that, because that does happen sometimes.
Just put an exclamation point under the always give expectations for the patient. What are they going to expect? Because you don't know what the patient is thinking is going to happen. And I always do try to underestimate so that I can overperform. Because it happens so rarely. I know you were thinking.
But I do like to combine, you know, like iontophoresis with oral medications. I like to combine iontophoresis for hands and feet with botulinum toxins for the axilla. And you're going to see this, I love botulinum toxin for the hands. It just takes a lot. It's hard to get covered, and there's a pain factor. And, you know, the first time it's the hardest. The second or the third time the patient comes in, it's a little easier because they know how much it's going to help their hands. It still hurts, but you're willing to put up with it when you know how good the results may be compared to other things that you've tried. Sometimes I had one person who was an amputee but had hand and foot sweating, and you have to make a circuit. So I had to have them do a hand with the one foot. You know, you just kind of mix the extremities up so you can get everything treated. So it is possible, or the same thing if they have metal, right, where, you know, you need to treat, you can just avoid that one and then use the other extremities.
Did you talk about adding anticholinergics to the water bath?
We did. When you tell them that, let them know that the tablets really won't go to complete suspension. They'll see little particles of the tablet in the water, and that's okay. It still can work. And usually I'll start with 2.5 milligrams in each tray, crushed up, and then I'll go up on adding more anticholinergic to the solution, to the water, if they're not getting enough improvement. And I actually start with tap water iontophoresis first, always, before adding anticholinergics to the water, because it's just simpler, cleaner. It just makes it a lot easier. But if they're not getting enough improvement, you can crush up tablets and put it in there. And you can use oxybutyn as well. And there are others, and that comes as a liquid.
There's another combination treatment. As I almost always will write a prescription for the topical glycopyrrolate cloth following microwave thermolysis treatment. I think maybe that for those patients who had the botulinum toxin before and are not going to be happy with their 80% improvement, it may help a little bit more. Question?
In patients that may have an occupational or a hobby that they need to regulate their body temperature, do you avoid or how do you counsel and mitigate that, say, risk for like a heat casualty or things of that nature?
So what happens when you have somebody who works outside or plays outside and they need to sweat a lot? I think you probably should not use anticholinergics systemically if at all possible. And we're going to talk about that a little bit later in more detail on an oral. I think you're doing the oral talk. So if you still have more questions after Adam's, but I would say you have to be very careful. And I'm always very careful with the other one I'm very careful with is teenagers, high schoolers in sports programs, because, you know, it's really hard for somebody who's trying out for the football team to tell the coach, you know, I need to sit down, and it just, they kind of get bullied into just getting out on the field and stuff. So, and then little tiny kids, I also am a little hesitant with, you know, 4-year-olds, 5-year-olds, giving them systemic anticholinergics if I can find something else that will control their sweating.
I wanted to hear about your experience with the workflow with the sodium patch. You know, is it nurse applying it? Is a doctor applying it? How does that work? And what sort of off-label indications or use do you think you might try this for?
Oh, that would be so much fun to talk about. But I'll first say the workflow for the patch. I'm not sure that it's the best for people who really sweat, those HTSSs of 4, even though they were enrolled in the clinical trial. And I think that patch gives us an opportunity to treat people that may not come to the office because they're not always bothered. And I think we're going to see people who are hearing about this. It's a more affordable option that might come in more intermittently. So, you know, like I could envision the college kid who's getting ready to go on interviews for their internship or something, and they need to feel confident and like they're in control of their bodies when they're going on those interviews. And that's a really good way to have something that takes no needles, no drugs, no anything, get 3 to 4 months of reduced sweating, reduced odor. I mean, that's a pretty nice way to go. So I think it's going to expand who's coming into the office. But I'm not sure, and I've treated a couple patients who have really bad hyperhidrosis, and it's hard to get them to dry off so that you don't burn them, because you're waiting for the water of the sweat to come up through the sweat duct and then hit that sodium, and that heat goes down and disrupts. So, but the flow is they come in, well, the first flow is talking to them on the phone that this is not going, it's going to reduce sweat and it may reduce odor. We ask that they have a clean shaven underarm, and so that's for both men and women. For people who have never shaved their underarm, we suggest that they shave at least 2 days before, because they may get a little irritated and you don't want nicks or anything in the skin or irritation. Then we have them come in, we explain it. We make sure that they're very dry. Typically, the recommendation is that you clean off with alcohol. Not that you really need to clean the skin, but if they have some irritation in their underarm from the shaving, you'll detect that usually when you wipe it with the alcohol, and then you may hold off on the treatment if they're really irritated from that. And then you really try to dry them off, and you put the patch on one underarm, and it's a specific size. So you don't need to do a starch iodine in that instance at all, because it is the size. And so you put it on, and then you explain to them that, you know, you're going to start to feel a little bit of heat. It may feel tingling, prickling. Let us know when it gets to a 2, a 3, you know, it's kind of that out of 1 to 10, what's the worst pain? And we really don't want you getting there. But once that heat starts generating, it starts to go up pretty quickly. And that's the time to start to get the patch off. So they say it's a 3-minute patch just because rarely does anybody need more than 3 minutes, but you definitely want to keep it on for 3 minutes if they're feeling heat. And sometimes I keep my hand on it to kind of feel the heat, because you'll feel it through the plastic, and then you take it off and wash it off. And then the patch has to be disposed of in a specific container to deactivate it. And then you go and do the other underarm. So in my office, the esthetician does most of them. Days that she had to call in sick, I'm the one that does it. So, you know, like anything, I think the physician has to know how to do everything and be prepared. There are days that I answer the phone, you know, I'm not great at taking the paper off the table, but other than that, I can do most things in the office. But it's a fairly straightforward procedure. And I always caution people to tell patients that it's easy, because if it's easy, then why am I paying you that much? You know, it's not easy. They gotta have sweat, not too much sweat. It's gotta be, you know, you gotta dry them off, make sure they're dry. Sometimes you have to make them sweat. You can make them raise their legs. You can make them put some heated blankets on. You can ask them some really hard questions about life if you want, how your taxes are looking, like whatever you think to make them sweat. But sometimes, you know, even people with hyperhidrosis don't sweat when they come in to the office for treatment, and you're trying to make them sweat. I'm like, dude, you sweated so much the last time I saw you, but the day you're coming in for your microwave, you're not doing anything. So that's frustrating.
And just to emphasize, this can be done by a medical assistant or an esthetician. You don't have to, the doc doesn't have to be there. But whoever does it has to be properly trained to understand these little nuances. It's not rocket science, but if all those little steps aren't followed correctly, you're not going to have a successful treatment.
We're going to have some more Q&A later. We're going to move on to some more lectures, and we'll be back up here to answer all your burning hot questions.
Oh, that's me. Okay. All right, so we're going to talk about the non-axillary use of the different toxins. And again, every single toxin is off-label, and all of these areas are off-label, but you're going to have to deal with them. So we talked about the axilla, but palms, soles, face, scalp, groin, under the boobs, in the crack of the butt. I mean, there's places that everybody sweats, and you have to be able to think about what would be things that you need to avoid or do differently about each of those areas. So we talked about, you know, the different areas. You know where that sweat gland is. It's right between the dermis and the deep fat. So you know how deep you have to go depending on the area. So, right, a groin is going to be different than a palm into how deep your injection will be. We talked about this. It's not to make everybody 100% dry, but to make them significantly better. Be sure that you're measuring. So the most of the area that I do second after axillas are palms. And some people will avoid the fingers, but you really have to treat the entire palm, including the fingers. So otherwise, if you only treat part, or they'll avoid the palm and only treat the fingers because they don't want to get weakness here in the thenar eminence. But if somebody's sweating here, it's getting all over the hand and vice versa. So you really have to treat all of it. So the issue is that this hasn't been well studied, so the dosing hasn't been worked out like it has been with the axilla. Pain is an issue. The duration is a little bit shorter, and then you can have muscle weakness, which can impact their daily living and their work. So on average, it's about 2 to 3 units or equivalent of Onabot, Botox, for those who don't know what the brand name is. Compared, so that would be about, Dysport, which is Abobot, is usually somewhere around 2.5 to 3 units equivalent to 1 unit of Botox. Onabot, or English, or Pratbot, to use all the generic names. And then the pain control is really a problem. So the things that you can try are topicals, like topical lidocaine. I don't find those to work well enough for me to really control the pain of the patient. Nerve blocks I used to do a lot of. I don't do them anymore, but I'm going to show you how to do them. Beer blocks usually really needs monitoring. They're done mostly in surgical centers where they clamp all the blood with a cuff. And so then they inject lidocaine directly into the vasculature, which numbs it up. And then once you release the cuff, you get a big bolus of lidocaine that goes back. So you have to monitor the heart. So most of us are not going to do that in our offices, but it's an excellent technique. Cold anesthesia, I'm a big believer on, and I'll show you how I do it. Vibration can add to the anesthetic control. General or IV sedation may be necessary for little children, but again, I don't think that's really worth it. The risk, but maybe there are pediatric dermatologists who might do it. Nitrous oxide has been tried with the new delivery systems like Pronox and others. And then some people really just grin and bear it, and they just, especially after the first time, like I said, the first one's always the worst, but once you've got good, you know it works, you're really happy. So if you're gonna do a nerve block, you have to get all 3 nerves. And the easiest to do is if you do it on yourself and you kind of bend your wrist just a little bit in, you'll see some of you will have 2 tendons, some of you will have 1. If you have 2 tendons, you want to take the needle and go right down in between the 2. Use a 30 or a 31 or 32 gauge needle with 1% or 2% Lido without epi. If the patient complains of any tingling, you need to withdraw, you're touching the nerve. And you inject, if you're using 1% Lido, you inject about 2 cc's. If you're injecting 2% lidocaine, you can inject about 1 cc. And then you come to your ulnar, and you can either go, again, if you feel that little tendon, you can go on the medial side and come to it, or you can go from the lateral side and go into it, trying to avoid, again, if you feel, the patient feels tingling, then inject. And then for the radial, my technique is very scientific. I feel the pulse, and then I try to miss it. You know how many times you tried to do an arterial stick and you missed, right? As an intern? It's pretty easy to miss, although when you're trying to miss it, it's amazing how many times you hit it. So what do? You take the needle out and you have your assistant hold, right, for 10 or 15 minutes. You go see another patient and then you come back. But it takes several minutes for those nerve blocks to work. So it's time, and I don't do them anymore. But if you want to, that's how you do them. And there's things on the sweathelp.org website on how to do nerve blocks for the hands and the feet. This is how I started. This is one of my very first patients, a college student from St. Louis University with severe Palmar hyperhidrosis. And I used to just put her hand in a bucket, and then when she said it was cold, I'd take it out and I would inject. Honestly, it works pretty darn well, but it didn't seem to be the most sanitary, so we've tried lots of other things. Ice cubes, frozen ice balloons, they don't really get cold enough. You can use a cold air machine like a Zimmer, but sometimes if the air is blowing on your needle, it'll freeze your toxin, your liquid. And then all kinds of different vibrators to distract the patient and to distract the nerve. So these ice cubes are what I usually had used, and then at a meeting that David and I were in Atlanta, someone showed us these. They're more rectangular shape. They're so awesome because now they don't roll. They're not circular, but they're really great to control the discomfort. So when you look at this hand, a lot of injection points about every centimeter, half a centimeter, depending. And I can cover an entire row of those injections because it takes about 3 to 5 to 7 seconds to get cold enough that there's anesthesia. And then I also press very hard with the ice cube. So now I've got pressure anesthesia and cold anesthesia all at the same time, and I just go across. And then if I'm getting to a really sensitive spot, I can go on top of it on the edge and really do that. So, I can do a set of hands usually in about 15 to 20 minutes. I think when you're first learning, you need to give yourself probably 45 minutes to do it because it takes a while, and you need to be very careful over the thenar eminence where the muscle, movie, but it says not allowed to play. I don't know. I don't use a Mac. Do you want to show me how, or an Apple? Really want to go superficial with these injections across everything, but especially over the thenar eminence because the muscle is so superficial. The skin is so thin that even when you're doing everything perfectly, you need to, it won't play. That's all right. You're going to see it live anyway, so better than this. But you just want to go very superficially. I usually, if I have my preference, I have the patient like sitting across from me, like if Adam is the patient, and his hand is facing this way. So if I can, I start with the more proximal, just because it bleeds, and then I go more distally. But if a patient prefers that I start with the fingers because it does hurt a little bit more, I'll start with the fingers and then work my way proximally. It really doesn't matter. But again, if I have my preference, I'll go from proximal to distal, just so my hands aren't in all the blood and my sleeves aren't. But very, very superficial. And usually for an average sized hand, I'm going to use about 100 units per hand, a small hand. For a bigger or medium sized hand, I'll use 150 units per hand. And then for larger hands, I'll use about 200 units per hand. I try never to use more than 400 units at a time combined, because early on in the Botox days, and it was Botox, so I'm using the proper name, if you injected more than 400 units for neurologic and rehab conditions closer than 3 months apart, those were the patients that started to develop neutralizing antibodies. So the newer batches of botulinum toxins have fewer proteins in them, and they've been sort of refigured, so it's a little bit safer, but I try not to use more than 400 at a time. You gotta really inject superficially when you're doing this. This is something that there it goes, that Ada Trindade de Almeida in Brazil came up with. She would take little insulin needles, and knowing that it's a needle about 2.5 millimeters to where the sweat gland is, she'd cut the caps off and then put the caps back on, and then she could go just straight down, and she could go very fast. And that works really well until you have somebody who has calluses and some thin skin and some thick skin. But if you have that, you can just do that. You can see how clever that is. So it's kind of a nice way if you want to use that. So a lot of times when I'm injecting, I combine, like I said, ice and vibration. So there's lots of studies that show that vibration, that a nerve can only send one signal at a time. So if you're causing pain, it sends that pain signal. If you confuse that nerve right before the pain comes with some vibration, it's sort of paralyzed and it can't send the pain sensation quite as well. So if you're going to do this, you need to sort of have that vibration at the last few seconds before you inject, because the nerve will recover pretty quickly from that with that vibration. And I know in Atlanta, a couple of the pediatric dermatologists were using those little buzzy bees. I tried them and it didn't seem to vibrate enough. It just sort of is a generalized distraction. But if you really want to use vibration to confuse the nerve, you've got to go with something that's a little bit more powerful. I showed you the one in the picture that we used. I have no ties to that. It's just the one that we found that worked pretty well, and we could put a finger cut over it so it kept the thing clean, so that we still would clean it, but it kept it clean. So these are some other options, but I haven't personally found them to work. I think feet are even more painful than hands, and I really try to use iontophoresis. It takes so much to cover a foot. I think the last foot that I injected was a bride who just didn't have time to let iontophoresis start working, and she wanted to wear heels and feel pretty, and so we injected her feet, but it was very, very uncomfortable for her. So craniofacial is another one that I do inject quite a bit for. It is, of course, off-label. Most commonly, you'll see foreheads. Sometimes you'll see foreheads and the ophiasis pattern, like you see in this guy, where just that, ophiasis rim is dripping wet. Sometimes it's all over. And I try to ask the patient, where does the sweat first start? Because once it starts, it's going to run down everywhere. So the first answer is everywhere. I'm like, no, when it very, very, very first starts, is it just here? Is it just here? Is it here? And try to really understand where it starts, because it's hard. You can't really do a starch iodine on the hair unless they're bald. So I'm showing you that there, but I don't usually do a starch iodine for the scalp, but I did it just for the picture. And when I'm doing that, I'm typically, for the forehead, I'm typically using, which I include the forehead and back a couple centimeters into the hairline or what should be their hairline, and then the temple regions. I'll use 100 units. If I'm doing that and the ophiaces, I'll usually use 200 units. And when it's globally, I'll usually use 300 to 350 units, depending on how big the whole scalp is. And again, it's right into, just like you're injecting for alopecia areata, it's just right down into that sub-Q. So somewhere around 2 to 3 to 5 units of Onabot equivalent, and about every 1 to 2 centimeters. You need to go very superficial so that you don't get a forehead droop or an eyebrow droop. Young people will usually tolerate it. If you have an older patient, you certainly need to let them know. Some of my older patients prefer to sweat a little bit and leave a little bit of active muscle right above their eyebrow. So you just need to talk to them. And then you can either, some people actually like to use a lower dilution. Instead of 4 cc's per 100 units, use 2 cc's per 100 units like they commonly would for an aesthetic injection. You may not get quite the diffusion as well, because remember with botulinum toxins, the greater the fluid, the more diffusion, the more concentrated, the less. But you just have to kind of play around with that. When you're starting to treat areas with gustatory sweating, you really have to think, or Frey syndrome, you really have to think about the muscles that are involved and anywhere around the face. So this is a patient that said that she was sweating from her nose and her upper lip. But when we did the starch iodine, you can see exactly where she's sweating from. It's not the entire upper lip. Where it starts from is right there in that little triangle. So you can reduce the dose of toxin that you need and reduce the risk of muscle incompetency by really targeting where it is. And then she really was only sweating on the side of her nose and the ala of her nose and a little bit up at the top. So you can really, this is where you need to learn how to do a starch iodine, even if you're not going to do it on every axillary patient, because you will need it. Frey syndrome is the most satisfying of any hyperhidrosis that you can ever treat because it works so well and it lasts so long. This is a patient of mine, and for him, it lasts approximately 20 months. So he lives up near Chicago and he drives down about every 2 years. When I have a patient call in for excessive sweating of the face, if it's related, we ask if it's related to eating. Then I ask them to bring whatever food substance that may most likely bring it on. For some, it's caffeine. For some, it's tart, sweet. For some, it doesn't matter. And that way, for him, it was sweet tarts. And so he would bring a roll of sweet tarts. And then I would do the starch iodine you can see here. And then I have him start eating the sweet tarts. And you can see now he's sweating. So you can tell that, you know, right in this area, I'm going to hit the buccinator or the rhizorius, right? So I have to have a discussion with him. Does he want me to go ahead and treat that area? And I'm giving him a mirror and I'm letting him see, you know, you may have an asymmetric smile, you may have some of these other issues, or do you want me to treat the more safe area, which is the biggest area, and just do it that? And you'll get different answers from different patients. Problem is, like most times when you treat toxins for muscles, right, it lasts 3 months or so. So it's a quick side effect, but this may last 6 months or more because of the effect of the nerves are all messed up from the Frey syndrome. And lots of studies have shown that it lasts a long time and with lots of different toxins. So you can really tell them up to 3 years, which is amazing. You can sometimes get this covered under insurance, but patients will pay for this. I mean, it just impairs their quality of life so much. So really, it's an amazing treatment. So what about groins? Again, people don't oftentimes know where they're sweating from exactly. So if you can get a positive starch iodine, it's nice. If you can't, it's okay. What I usually do then, if I can't do it or I can't get a positive, I'll treat a couple centimeters lateral to the inguinal crease. And then I'll usually treat about 1 centimeter medial just because I don't want to get too much of the labia hit. So you're trying to stay and you go down as far as you need to. This is a nice way that my esthetician kept the patient sort of comfortable with not being too exposed during the treatment. But and then you just sort of count up the areas, and I plan on injecting about 2 to 3 units at each site. And then you can see how that goes. You can use it for submammary as well. Again, a starch iodine is very helpful because it may be a small or a fairly large area. If I can't get it positive, then I usually go a couple centimeters to 3 centimeters superior to the inframammary crease, and then several centimeters below the inframammary crease. But some will have a pretty short width of sweat, and some will sweat the entire length of the mammary crease. So if you can get a positive starch iodine, it's very, very helpful.
5 units of Botox every 2 centimeters.
God, voice of God. This is an interesting patient I wanted to show you. So she was referred by a local dermatologist who's a very good dermatologist. And he had treated her forehead and lip for excessive sweating, and it didn't work. And so he sent her to me. And once when I let her, it was worn off. It had been like more than 6 months by the time she could get into me, unfortunately. And so I did a starch iodine, and you can see it's just a tiny little part up here. So he had put the entire 50 units, or whatever he used, all over the whole forehead, and probably didn't get enough where the actual problem was originating. And then you can see it on her lip. Again, it's just a little swatch. It's not the entire length of the lip. So by doing this, you really are able to give the most concise and optimal results with the fewest side effects. So I just can't stress being able to do that enough. So in summary, Onabot is on label for axillary disease. It's off label for everything I talked about: Abo, Dysport, Inco, Prab, Jeuveau. I have treated one patient with the new Daxxify, which is, at least for cosmetic results, can last 2 to 3 times longer at higher doses. So I treated him with, and I've been treating him for 20 years, so he was up for the challenge. And so instead of 50 units of Onabot or Botox, I gave him 100 units in each underarm of Daxi. And his Botox treatments, he'd start sweating at 4 months, 3 to 4 months, he'd be back, just to what you were talking about. And he's at 9 months right now with the Daxi, and he hasn't started sweating yet. So I'll keep you guys informed. I don't know. And he's 1. He's an N of 1. So don't go and switch everybody to Daxi or something. I mean, I just did it for that. So we talked about intradermal, which are to very deep intradermal sub-Q injections. When you don't have a dosing regimen that you know, kind of stick to maybe 2 to 3 units. There's a paper by Noel Solish that looked at different amounts for different parts of the hands and fingers. You can look that up. That was too taxing for my brain. Starch iodines can be helpful. Always ask where it starts in these areas, especially in the scalp. And then control for that depth of injection, because you will get some muscle diffusion. So I can answer questions later about this, but I'm going to let oral medications come in.
Thank you for that. So oral medications, I think, enter the scene when you have, too many areas kind of coming across your plate. That doesn't mean, as you heard before, that you can't do combination therapy where you may focus on an area like the palms and soles with injections, but a patient has multifocal disease. Wouldn't it be nice to bathe someone in Botox? That's not very realistic, where you are targeting the person and what their complaints are versus just trying to focus on each individual element that's involved. So I think oral medications really come into play when you have multiple sites and you need to take a holistic approach. Now, unfortunately, not a single oral therapy we use is on label. There's theoretically one that's coming that we've heard about for way, way too long. So I'm a little pessimistic that we won't see, but hopefully we will. But just because it's off-label doesn't mean we can't get on with it. As I think we are incredible at employing off-label therapies based on our training, understanding the mechanism of medications, pathophysiology of disease. So this is certainly within our wheelhouse. But once again, you're really going to start to think about systemic therapies when you have someone with multiple sites. And that's really where the International Hyperhidrosis algorithm comes in. This is going to enter that scene when you have someone who has maybe axillary, palmar plantar, inframammary, craniofacial, where it would be very difficult to take a targeted focal approach for all of those. But also you have to consider that patient who doesn't want to join you in your enthusiastic train to doing all these different things. We may think, oh yeah, we can do injections all these places. You can use a wipe every day. A lot of patients want to hit the easy button, and for them, a pill may be that easy button. So it's not just about where it fits in from a medical perspective, but also what is a patient willing to do, marrying efficacy and, of course, safety when it comes to that. So first on the list are going to be anticholinergics. The one probably most commonly used is glycopyrrolate. Because of its access, it's pretty cheap. It's been around for some time, a lot of flexibility with dosing, and I'll talk about how I do that dosing and really give ownership and really empower the patient to kind of do a sliding scale. I will typically start a patient on 1 milligram twice a day. I think it's really important, and what I'm about to say, I will give full credit to Dr. Pearser, who kind of gave me part of this script, in that we tend to think about treating things from a spot perspective. I know in the commercial space we have acne spot treatments, and maybe there are some things that are spot treatment-esque. But when it comes to anticholinergics, this does not work like, oh, I'm going to go out tonight and I don't want to sweat, so I'm just going to pop some glycopyrrolate and that's it. This takes time to build up. It takes time to have the effect. So it's important to emphasize not only do you want consistent use, and I think twice a day versus once a day dosing has a more meaningful impact, but also the patient has to be on it for some time for it to work. You can't just start all of a sudden expect to get a magic from one dose before, of course, going out. And we also have oxybutynin, but I feel like there are more side effects associated with its use. I think there's some more flexibility in terms of the vehicles available, but as opposed to glycopyrrolate, I think it has more CNS impact. So I tend not to use this in my practice unless someone completely fails pretty much everything else. But this is something I hold back on. I definitely leave in with glycopyrrolate, given the, once again, ease of access. I don't think, has anyone here ever had glycopyrrolate denied by insurance? No, it's like pennies on the dollar. And then once again, there's a lot of flexibility. You can tailor the dosing regimen to the patient. Now, the other thing I'll say about more about oxybutynin, though we do have some data with glycopyrrolate, is that oxybutynin first started off in the pediatric world. And while not for hyperhidrosis, I think that gives us some credibility when talking to maybe a parent about a medication, because that's really who you have to convince, not so much the kid, that if there's data in the pediatric literature, it gives you a little more comfort when employing something. And we'll talk about some of the considerations which you already heard about when it comes to anticholinergics in kids. It just makes you feel a little bit better that there is some safety data in this population. So as I mentioned, I take a kind of sliding scale, and we're all really, I think, familiar, regardless of how far out we are from our internships. We remember those awful lists of my day to write out a sliding scale for insulin. But as I mentioned, I start with 1 milligram twice a day, but my prescription is often for much more than that. And I like giving the 2 milligram pills because they are straight in the middle. They can break them really easily. And so I'll have a patient do half a pill twice a day. And then over time, and I usually will say maybe over a week period, they'll start to 1 milligram twice a day for a week, see how they feel, assess side effects. So the side effects do kick in pretty quickly, especially the dry mouth and dry eyes, but more dry mouth. And then I'll have them dose escalate by 1 milligram on either side of the day, usually up to about 6 milligrams for the day. I will say I've gone higher, But this is, the side effects are dose dependent. So the higher you go, the more likely you're gonna get those side effects. But usually, most patients can't tolerate higher than 6 for the day. But I have a couple who are on 8. I don't think I've ever gone higher. You guys gone higher than 8 for the day? Rarely, yeah. Courageous to go to that 10. Once again, long-term therapy is required. You cannot just say, take 6 tomorrow and you'll be fine for whenever you need it. It doesn't work that way. The same is true for the topical anticholinergic you heard about. I will say it kicks in pretty fast. Usually by day 5, a good number of patients will see something, but spot treating does not work. Major side effects, which I'll get into, dry mouth I think is number 1. Dry eyes, I've not seen a whole lot of, to be quite honest, but xerostomia definitely. Urinary retention or hesitation, I haven't had a ton of patients report that, but it can happen. I often will tell my patients, if you haven't gone to the bathroom in a really long time, you may want to try and force that out a little bit. But I personally, fortunately, knock on this artificial wood, have not had that so much of an issue. Blurry vision can kind of fit into some of that dry eyes. I have not seen so much of that, but definitely xerostomia is probably the thing that drives people crazy the most. There are a lot of things that can happen. This is a very lengthy list. Do I run through all these with my patients? No. But I think it's just something important to know about. The other thing I want you to consider is, in the same vein, antihistamines have anticholinergic effects. And we use high-dose antihistamines for urticaria, whether it be acute or chronic spontaneous urticaria. So just be mindful that these same side effects can apply to high-dose antihistamines as well. The other thing I want to mention, why I don't call this a side effect, but something that you need to know about, there was a paper that discussed the correlation of anticholinergic and chronic anticholinergic use and dementia, which scared a lot of people. This paper was in the elderly. It was a whole broad range of anticholinergics. I think the current dogma is certainly don't ignore it. A patient brings it up, but correlation does not equal causation. I don't think there's enough data to really support that these long-term can cause dementia. Full disclosure, from that first presentation I gave, there's a picture of me as a resident, very proudly displaying my hyperhidrosis. I do take glycopyrrolate 2 milligrams twice a day, which obviously I hope would say shows that I'm not concerned about that side effect. I've been on for years. And what was I saying? Just kidding. Too soon. Now, once again, back to pediatrics. We have data on these anticholinergic in pediatrics. Glycopyrrolate, actually in the world of hyperhidrosis, there have been some small studies, one with Amy Paller, glycopyrrolate in 31 pediatric patients, oxybutynin started off in that space. So I think why it's important to know this is when you talk about this with a child, an adolescent, and their parents, this is not you being Doc Brown from Back to the Future. There is evidence to support the use of these medications and, of course, their safety. Now, what if it doesn't work? And not every patient will respond, but I think there are also patients, and I just saw one recently, who just refused to go back on an anticholinergic because of the side effects. Once again, that's xerostomia, which I think was very disabling. There are some other things we can certainly try. This was an example of using oxybutynin where glycopyrrolate failed in certain areas. And I think the responsiveness as well as the tolerability can vary between them. So I think that's one option. But we have things outside the anticholinergic world. So beta blockers, I think, are a good option, especially for those patients who have an extreme exacerbation of hyperhidrosis in a stressful situation. So, for example, standing up here like this in front of an audience, maybe having a good presentation at work. So I do think of this as kind of like a one-off type therapy. I think it does work pretty well in that one-off setting. So as I said, anticholinergics take time to work. This works pretty fast. The way I tell my patients to use this, so first off, I want to do a dry run at home, safe environment, carpeting, no pressure, just to make sure they tolerate it. I don't know if any of you remember the show ER. There was this very famous episode where a resident was at a national meeting and was very nervous and took a beta blocker before going up. And then literally as she was walking up to the podium, missed it and just passed out. We don't want any of that. So I think it's important to do a dry run. Also, just important to know, are these patients hypotensive at baseline? That's something to consider. But, you know, bradycardia is a contraindication. Asthma is another one. Those are probably the two biggest ones. And yeah, of course, AV block, that should be obvious. But bradycardia and asthma are the two big ones to really think about. Also, I threw this in here because this often is a board question. Beta blockers do exacerbate psoriasis. Just be aware of that. And so if you have a patient with a psoriasis who is just not responding the way you would think, knowing all the comorbidities that patients get, think about beta blockers. So just a tangential aside. Clonidine, probably I don't use as often. I find this more effective in the patients who have hyperhidrosis and flushing. I probably use it more in rosacea, you know, the kind of persistent erythema that's the centerpiece of rosacea, but especially those patients who have persistent erythema and maybe some sweating associated with it. I find it very effective. We use very, 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 very low doses. And there are some small cases and case series showing that it can be effective. I usually start a half of the smallest pill possible twice a day and work up to maybe at most 0.3 milligrams for the day. But there are certainly some reports of it being useful when all else fails. So I would not consider this a first-line therapy. I really think that this would more be a second or possibly third-line therapy, but usually well tolerated. I think most of my patients on this are taking it for rosacea, for that persistent erythema after a topical vasoconstrictor fails. But I have tried this in patients who refuse to be on an anticholinergic. You know, beta blocker consistently probably is not the best approach. I'd love to hear from the group if you have patients on consistent beta blockers, but pretty well tolerated and can be useful. You know, and lastly, there is this relatively older paper in what was then known as Archives of Dermatology, now JAMA Dermatology, where they used a calcium channel blocker for a patient who had pretty much failed everything. I'll be honest, I have never used a calcium channel blocker for hyperhidrosis, but I was kind of pulling hairs to try to think of other things you can use. We really have a limited armament, unfortunately, but we have one. And I think it's really important to be comfortable with it, know how to educate and counsel patients on it in order to employ it when necessary, whether it be as monotherapy or in combination with, at a minimum, antiperspirant at night, maybe deodorant in the morning, or maybe a topical. I would not combine a topical anticholinergic with a systemic, as Dr. GLASER mentioned. Not just in terms of knowing what works, but in terms of compounded potential for side effects. But it's good to know what off-label options we have so we can run wild and be bandits. But repeat to yourself, go low and slow. You know, this is a chronic condition. Rome wasn't built overnight. Patients want to get better yesterday, but ease in, because if you go too quickly, the side effects might scare the patient off when they may have done quite well, because a lot of these side effects will burn out over time. It's usually there's a front loading of those side effects. So you really want to ease them in and get them comfortable for long-standing therapy. Thank you.
So how many of you are going to do ETS surgery? No? All right. This is not to make you want to do ETS, but how to counsel your patients when they come to you and ask you, you know, about surgery and should they do it, and maybe why they should or shouldn't. So there's a lot of limitations with the literature, and usually it's very short follow-up time in terms of the side effect and the duration of effect. There's a lot of different surgical techniques, and so it's not a very consistent. Every surgeon does a little bit different. There's really no large randomized trials, and a lot of it is just retrospective data from a single surgeon where they'll go back over a few years and look at their patients. So sympathectomies have been around truly since the 1800s, and then in the 1980s it reemerged when endoscopic things were going on. And so there's lots of ways you can resect it, you can clip it, you can burn it, you can cut it, you can do all kinds of things to get that ganglion under, you know, to disrupt. But when the endoscopic techniques came on, there was a lot of renewed interest in doing ETS. And it's usually same day the patient goes home that afternoon. And so it seems very easy to the patient. This is great, it's permanent, you know, I go in, I come out, and I'm done. But there are more problems to it than that. And usually this is what the ganglia look like. And usually it's cutting somewhere either 2, 3, 2, T4, T2, 3, or 4, or a combination of those. And it depends on whether you're treating palmar hyperhidrosis or craniofacial or axillary. Will depend a little bit on what the surgeon does. So these are the cure rates that are published in the literature. So 95% for palmar patients. But when you really dig deep, about 7 to 40% have recurrent sweating. So it's not quite as permanent as sometimes people think. Satisfaction is usually very high initially and then declines from the patient over time. One, they may have start sweating in the area, or they may start having some side effects. And we know that cutting at least T3, and if you do T3 and T4, you're going to get the best efficacy. But a single ganglia always has the lowest side effect risk. So we don't, like I said, we don't really need to know all of the details about how to do the surgery, but we do need to know what happens. So when you look at craniofacial, you know, there's only about 83% who were satisfied in one report, and about 83% of them had compensatory sweating, meaning they started sweating elsewhere on their body. I will sometimes recommend this for somebody who does have severe craniofacial, usually associated with flushing. I do try diltiazem in those instances. I do try clonidine before I recommend it, but I do sometimes, and they oftentimes will get improvement, but they still can get compensatory sweating. Plantar hyperhidrosis is wrought with potential side effects with sexual dysfunction due to the nerves. There are about 3 to 5 neurosurgeons in the country that say they can do it without any risk of sexual dysfunction, but I usually tell my patients with severe plantar hyperhidrosis it's not a good option for them. So the complications are, that's where we're really getting into. We can deny how well it works, but it does work. But it's the risk, the benefit ratio that I think that we have to struggle with. So compensatory sweating is greater than 50%. And oftentimes it starts much later post-op than the first 6 months. So a lot of the surgeons will follow their patients for 6 months to a year and say, see, it never happens to me. And I have a cardiothoracic surgeon that I do send my patients to when I feel like that is the right choice. And I call him afterwards, and we've known each other for 30 years. And if the patient 7 years later calls me and says, yeah, now I'm sweating from my chest down, you know, I call Keith up and I'm like, I really am sorry, but Ben got compensatory sweating. Not to make him feel bad, but just so that he knows, because a lot of times the patients don't call the surgeon 7 or 8 years later. They come to the dermatologist for treatment of the problem. So I always call just so they have an idea, because I don't think the surgeons are trying to hide their complications. I think they're just not hearing about them that far out. And it can be mild, the sweating, or it can be very severe. Horner syndrome, it still can happen, but not very often with these endoscopic techniques. Pneumothorax and hemothorax can definitely happen, and some of my patients have had that, but it's treatable. You know, they just put a chest tube in and it goes away. Paresthesia, just put a chest tube in, come on. But there are some others, hyperthermia and bradycardia, and those have been some more severe ones that are associated with it, even to the point of requiring pacemaker, and those don't tend to reverse. So again, sweating occurs, compensatory sweating, in about 50%, but really the literature supports 20 to 80%. And it does correlate with the extent of the surgery. So if it's 1 versus 2 versus 3 ganglia. It can begin as early as 2 to 8 weeks, but it can take years before it starts to develop. And the earlier it develops or the later it develops does not necessarily correlate with how severe it will be. It's very difficult to predict how severe, and it's nearly impossible to treat once it occurs. Gustatory sweating can also occur in a smaller group of people. So again, talking to the patient that if they really feel they need to go, that they understand that the extent of the surgery does correlate with the potential risk, and talking to the surgeon about a more limited surgery. I try to send the patient to the surgeon that I know and trust, and so I think that's a good idea if you can find that person. And then lately, there's been a lot about clipping, right? You guys are hearing a lot about that. If you clip it and they develop compensatory sweating, you'll just unclip it. So easy. But the problem is multiple studies have shown that clipping does not reverse the compensatory sweating. And then even patients that it's tried on. It's not like, when somebody has other kinds of clips that are put in and you can take them off and reverse them. But anyway, clipping does not reverse it. And so you really have to tell patients that, because surgeons will say that. So these are some of my patients who have come back or have had compensatory sweating from ETS surgery. This is really bad. This is not something that's very tolerable. This is his back. So you tell him, don't wear gray. Why don't you wear white? Well, that didn't help much, did it? And I mean, we have tried everything for this guy. We've done orals, we've done topicals, we've done inject. You just can't inject everything. So, and this won't go away for the rest of his life. This is a woman. It's kind of hard to see, but this light pink over here is the only part of her shirt that's dry. I couldn't I have a picture of a patient who sweats all the way down into his groin, can't wear khaki pants. When he does, it just looks like he wets his pants. I mean, this is really, really terrible. Here's another one. So I think that, I put these letters in for a reason, because I do want to tell you that there are people who are very happy with this surgery if they haven't had complications. So my son had surgery for his hyperhidrosis at Hopkins in June. He's now worse than before. He's tried many medications, nothing works. I know they can get compensatory sweating afterwards, but this is incredible how much worse he is. Any thoughts? I write to you in desperation. I'm 40 years old and I've suffered with hyperhidrosis of the hands, feet, and underarms for as long as I can remember. I had ETS approximately 5 years ago. The surgeon who performed this advised that I may have some compensatory sweating, but he really glossed over this fact and was more concerned about informing me that my eye may droop. I certainly would never have had the operation done if I had known what I do now. The hyperhidrosis of my hands and underarms is cured, and that's great, but now I suffer from compensatory sweating, which goes from my trunk all the way down to my feet. As you can imagine, this is far worse than my original condition, and it has caused me great distress and unhappiness. If I thought my life before the surgery was bad, there's nothing compared to this. I am constantly wringing wet. I have read your emails and on your website several times that you do not recommend ETS surgery for teens. Can you tell me what the complications you are referring to when you say that it is not an acceptable option for most patients? My 16-year-old daughter had surgery in October, and so far it has turned her life around. I'm wondering if the complications you mentioned would have already surfaced, or if we should be aware of some that may show up in the future. So obviously the answer to that is yes. So I think that the thing to realize is it can be a very effective treatment, and it can be an effective treatment for people who've really tried everything and they're desperate, but their desperation may still get worse if they have severe compensatory sweating. And so really trying to describe that and tell them that it's not worth it. I also inform patients that the country Sweden has banned ETS surgery for hyperhidrosis. And I tell them that I would honestly never have one of my children ever have it, even however bad their hyperhidrosis might be. So I try to make it personal so that they know that I'm not just trying to bash the surgeons or keep them so that I can do microwave or whatever it is on them, or tap patches or things. I really want them to understand that my concern for them. So I'm happy later to answer questions about ETS or how to counsel them. But it is a real issue, and it does seem easy, but boy, these patients who have bad problems, they have really bad problems. So next up is decision-making. Okay. So this is going to be sort of a short, kind of interesting talk about how we make decisions on how to treat and who to treat with what. So I'm going to give you a case of a 27-year-old woman who wants to work in the beauty industry. She's had axillary hyperhidrosis since her early teens. She says she's tried everything. Antiperspirants, they were not effective. They gave her big white streaks. She hated it. She tried to get insurance to cover Botox because she heard that worked really well, but they wanted her to try glycopyrrolate wipes and they wouldn't cover that. And then she had to pay $500 and she was unhappy with that. She liked the effects of the botulinum toxin, but it was a nightmare, she says, because there was always denials. She never knew if she was going to be able to get it at the next time. The prior authorizations took so long. One time the insurance denied to pay the doctor and the doctor expected payment from her. So she wanted to look for something else. So over the day, you've kind of heard about these things that we can use to treat, right? Topicals, iontophoresis, botulinum toxins, oral medicines, local surgeries and different procedures, microwave thermolysis, the ETS, and the newly FDA cleared Brella patch or tap patch that you heard about. So how do we choose? I mean, some patients come in and they know exactly what they want. Maybe you don't think that's the best option, right? Do you go by just what's FDA approved? We've already heard that as dermatologists, we almost never just do what's FDA approved. We love to do other things. But is that your first line because it's FDA approved? Is it by how much literature has been published, whether it's a controlled trial or case series? Is it how much does your personal experience, like if I do 2 of these procedures and both patients in a row got bad results and both had complications, does that mean I never do it? Or am I able to look at the literature and say, or talk to my colleagues and say, I just must have bad luck those first 2, maybe, or maybe I did something wrong. Maybe I need to have somebody come and help train me again. Is it by the side effect profile? I'm telling you that maybe we shouldn't recommend ETS because of its side effect profile. Not that we choose it because it has a good side effect profile. Is it because the pharma rep came in and gave you some cool coupons and some things and you thought, okay, I'm going to try this? Is it ease for the office? I mean, you've heard how complicated it can be to get approval for different topicals and for botulinum toxins, and it can take 3 or 4 staff multiple hours to get this to be approved. Cost has to play a role. I mean, for some patients, maybe less of a role, but for some patients, a big portion of it. Or do you go by your colleagues' recommendations? And obviously, this is a combination, but I thought we would sort of open this up. We have all 3 people here with microphones. You guys want to stand up and talk to the audience about how you guys choose, or what's your algorithm for choosing?
Well, let me start off because there's no one algorithm that's going to fit for every patient. And if you have all these 10, whatever they are, possibilities, some are going to weight higher for some patients than some other. You may have a very limited choice. I mean, you know that maybe this patient has the kind of health insurance that it's not going to cover toxin, it's not going to cover iontophoresis. You're going to have to give them an oral therapy, at least for a while, as for a trial. So it's, there's obviously science to this and there's art to this, but there's also the practical realities.
Yeah, I mean, sadly, the practical realities often drive our decision making. The best medication a patient can get is the one they can get, which takes our expertise and experience out of the mix. We go back to the actual case.
Oh, yeah.
So, it's interesting because obviously she would love to have more injections, it sounds like, but can't because of administrative issues. How did she do with the glycopyrrolate wipes, the glycopyrrolate?
Well, the insurance wouldn't cover it, and so she had to pay $500, even though the insurance says she had to try it. They wouldn't cover it before she could get to the toxin.
So you have to try something they don't cover to cover something else. My brain hurts.
Yeah.
So I think, Dr. Parris's point is, I think your first visit when someone comes in like this is to kind of figure those things out, ask, what are they willing to do? You heard that a lot of patients are willing to pay out of pocket to do whatever needs to happen in order to get better. Some patients can, some patients can't do that. But I think it's important to hear what their expectations are, what they're willing to and able to do. And that's then when you give them the menu of those options, whether it be monotherapy or kind of combination therapy. I think that the patch could be potentially an option for her, but we don't know the person's financial situation. But I think this also speaks to the point that we need more innovation in this space, that we really have a limited therapeutic armament or even from a device-based perspective. So this case is a great example of why we need more options.
I will say, those of us that work with the military or at the VA, it's very easy for us to get Botox and even glycopyrrolate cloths and things like that. So our residents probably have done more Botox than anybody for axillary hyperhidrosis, multiple cases a week. But that being said, I really find a role for oral agents, oral anticholinergics. A lot of our patients are on those and do very well with them. Only a handful of times have I had patients, often especially younger patients, develop really bad nightmares related to their PTSD using oral glycopyrrolate. So I find that this patient would that's where I would first go for sure, because it's affordable. She's young, and I think it's certainly worth a shot. So,
how able are you to get from like Palmar or other areas that are off-label? We
can just order Botox, and nobody
asks where.
So, because it's used for migraine. So
that's your taxpayer dollars.
That's the VA, or is that heaven?
Heaven.
Yes, here. We have our other problems, so.
Yeah, so, you guys are right. You have to really sit down and ask the patient and kind of go through it and see what you can do and trial and error. But I think one of the points I wanted to make is don't let your own maybe failures the first one or two times where it may not have worked as well as you wanted, or you might have had a side effect or a complication, stop you from doing that again. Maybe take a look at why you may have failed or didn't do quite as good as you wanted, or was there something that you did that you could change to prevent a complication or a side effect? But a lot of times we get cold feet very quickly, and then we don't want to go to that, and we just have to.
One thing that I hope you will learn from this day, which you never spent a whole day thinking about hyperhidrosis, or never will in your life, but you've all heard lectures where here's the treatments for axillary hyperhidrosis, boom, 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 and nobody tells you anything about the practical realities of any of them. And it's not rocket science, but there are nuances to every one of these treatments that we do. And particularly with the toxin injections, which you'll see this afternoon and do this afternoon, if you could walk away with one thing of the whole day, it's to feel comfortable doing toxin injections on the hand. And you will be amazed how easy it is and how simple it is with the ice and the pressure. And you're going to be amazed. You can just drop your jaw. You see how this really works.
I was worried you were going to say drawers.
No, well, that's later on. That's the afternoon business. Even with the wipes, with Iontophoresis, again, not rocket science, but there's a lot of little minor things that make the treatment really work or not work. And
so I put this together in the summer just to kind of go through what an average cost would be. And the topical antiperspirant was actually per unit. It lasts more than a month. That's just like the clinical strength. So the topical anticholinergic, the Qbrexza wipe, when I went to both GoodRx and Walmart, was $676. So FDA approved, down to kids, low side effect profile, a lot of great check the box until you get to the price, right? Iontophoresis, depending on the device. And now we know that the newer Dermadry has come down in price, but it's durable. I mean, that darn machine lasts for 15 years. It uses tap water, pretty darn cheap, you know. I do have my patients who travel overseas or go like take a trip that for either a short time or long time. I give them a letter of what the device is in case the TSA tries to take it away from them. And I so far have not ever had a patient who was not able to get their device through. I usually suggest that they actually take it with their hand luggage and so that they don't take off the luggage and think that there's a bomb in there or something. But I've never had anybody not go through. So when you look at botulinum toxin, you know, somewhere around 1,500, 2,000 every 6 months. Darn good effective, but you know, it's a really, it can be very expensive. And then as we're talking off label, you know, maybe not covered and maybe more pain. Oral medications, glycopyrrolate generic, $12 for, I use 2 milligrams BID. So that's for a month, $12. Microwave, you know, if you're using 2 treatments, I think, you know, most people are charging somewhere around 3,000 and even higher, but it's permanent. And the tap patch is, you know, just rolling out. So there's an introductory price, but, you know, I don't know exactly where it'll fall, but I'm guessing somewhere in that $400 to $500 per treatment if I had to guess. But it could be less, it could be a little.
But I have one suggestion for your patient, and it's, I haven't made this suggestion to a patient for a long time, except for this last week, for somebody who has terrible problems and basically has no insurance and no ability to cover. You know, I'm one that likes to have safe, tested, and effective medications. But you can get glycopyrrolate wipes off the internet from a site called pharmacy.ca for way cheap. And I've never, I don't like to recommend those because we have a commercially prepared, tested product. But for the first time in probably 2-3 years, last week we did recommend somebody go on that website.
I do every once in a while. It comes in multiple concentrations, 1%, 2%, 3%, all the way up to 5%. I usually tell the patients to start with 1 or 2%. What I have found is that there's an inconsistency in the amount of liquid in the wipes. So they're not uniform. And so some days there's more anticholinergic in it, and some days there's less. And I'll use it for other areas, like sometimes I don't know why I see a lot of patients who have crack sweating. And so sometimes I can do that. Sometimes I've had to do botulinum toxin injections, which I didn't cover, but for that area. But you know, what do you have to worry about? You have to worry about the muscle that's around the rectum. And so you have to be sure that you stay at least a centimeter or so away from that so they don't get fecal incontinence. So it's sometimes a wipe there is kind of nice. You can also have it compounded into a cream or a gel. And that can be effective, but it's really based on your compounding pharmacy. And if it's, again, consistent, I love that for bald people. I was going to say men, but some women are bald as well, because it really absorbs well when they've got a lot of hair. It's very hard to get creams down there. The wipes, you can sometimes get a little bit of it down to in a liquid formulation down, but I don't find it works quite as well as a cream. So again, you may have to be creative for your patients as you're trying to help them.
Just want to circle back to something you mentioned about failure. I think it's really important. You may have a patient come in and say, well, I tried that before, it didn't work. It may not have worked in someone else's hands, but maybe in your hands it will. So don't just like end the discussion there, like, oh, I tried that before, it didn't work. Okay, well, how did you use it for how long? Make sure you're asking those questions, because maybe it wasn't used the way you would do it and it wouldn't actually work. That's true even, obviously injections, they're not going to know about units and stuff like that, but you can get old notes. So before like dismissing a therapy, especially since we have so few, make sure you understand what that failure actually means.
And maybe when you combine it with something else, even if they actually did fail, whatever it was, maybe when you add that extra thing. But I agree, the patient says, I took that pill once and it didn't work.
Right. Or I had Botox injections in my hand. They did 50 units in my hand. It didn't work.
It didn't work, right. That's
The whole unit.
And yeah, go ahead.
For when choosing a treatment for like women that are like menopausal or even like premature ovarian failure, things like that, are you more hesitant to use anticholinergics, like if they're already experiencing dryness? Have you ever kind of experienced that?
But they're having excessive sweating.
Yeah.
Yeah. So I use clonidine quite a bit in menopausal women for sweating, and then oftentimes we'll add something else to it as well. But I think clonidine actually works pretty well for that, and especially if they have a history of flushing, as Dr. Friedman said. But in that case, then I don't have to worry about the dryness. And then sometimes if the clonidine isn't working well enough, then I'll add lower dose anticholinergics. So yeah, you can definitely do that. And I don't worry too much about it. Yeah. And for those of you who, remember in your internship, like with clonidine, when you're really treating for severe hypertension, if they stop suddenly, they can get this massive rebound. And you don't get that when you're normotensive and you're taking clonidine. So you don't have to worry that if they skip a dose or something, they're going to go stroke out from a severe hypertension episode.
Question for you guys, you ever use propranolol ongoing or just in the kind of like spot treatment?
Doesn't work as well there, yeah. And there's a ton of data in orchestra players and in surgeons using propranolol. And so if they take it on an empty stomach, 30 to 60 minutes. If they take it with food, they need about 60 to 90 minutes for it to start working. And it'll last for a couple of hours. So, they have to really time it. They have to know that it's going to happen.
And always do a test run first.
Yeah. And I actually asked them to test for orthostatic hypotension. So after about 60 minutes, I make them sit down for a little bit and then suddenly stand up to make sure that they're not orthostatic. And also, if it really slows down their heart rate and their blood pressure so much, sometimes they don't think as well. So I asked someone to have someone ask them questions and have a conversation that they would have so that they know that their cognitive flow is good.
Just one specific comment about I tried it and it didn't work. The iontophoresis device called the Geriatric, which is a battery-operated toy that has been around since the 1980s, is often what I hear when I say iontophoresis. Oh, I've tried that, it didn't work. So remember that one.
It doesn't work. And it's much more painful. So when they say I tried it, it was too painful, then I would say, oh, was it the dry ionics? Oh yeah. Yeah, it doesn't work and it's very painful. We got something better for you. You had a question.
Yeah, with the propranolol, are you worried about like a lot of young healthy people like live at like 55 to like 59 heart rate? Like worry about them, or it's like people with like true bradycardia?
True bradycardia.
Like a runner has a low resting heart rate.
Exactly,
Yeah, I'm not.
And again, these people aren't going to be taking it all the time. I mean, those are just general contraindications. But if they're taking it once, every few weeks because they've got to meet with their boss or have a presentation or something, then it's pretty safe. So a question.
Yeah, the side effect on that propranolol, a little bit of ED, that it does go away after the medication wears off. And then also if they have like a peak heart rate of 165, 170, now their peak heart rate is going to be 140. And so if they go to get on the treadmill and do their normal workout after their workout, they might experience some chest pain or other things because their mind is pushing past what the propranolol has brought their heart function down to.
You probably shouldn't do a really hard workout for at least 4 to 6 hours, even maybe longer after that. Thank you for that.
So I know trying to control for other external factors. For the oral, thank you. For the oral anticholinergics, has anyone had to like escalate? Like if the same dose is working for the patient for years, has there been times where they have to like escalate dose? Can someone get like resistant to the certain doses?
That's a great question. I've never had it. I've never had a patient come back and say that, but maybe.
When they get on a dose that works, I've never heard them come back and say, wait, it doesn't work anymore. That's a great question, because we know obviously with some of our therapies like biologics that can happen. I've never seen it. When we find the right dose, it tends to keep working.
And in order to find the right dose, it's really important to do that slow up titration. No more than 1 more milligram a day per week till you get to the point. And usually I go to the point where either they say my sweating is good enough, or they get to the point of dry mouth. And if they get to the dry mouth, then they go back one. So that by slowly titrating, they get used to it. You know, you can find a stable dose, and usually they can stay on that for a long time.
And some patients really will respond to one better than the other. And I totally agree with Dr. Friedman about trying the glycopyrrolate first because it is at quaternary amine and it doesn't pass into the blood-brain barrier. But there are lots of patients who get much better results with oxybutynin. So don't be afraid of it, but I mean, I do think it's a safer bet with the other one.
Going back to cold anesthesia, if you can't use ice, can you talk about using cold spray, like liquid nitrogen spray, and like minimizing the pain of the patient versus putting them at risk for the side effects of cold spray?
Yeah, so cold spray, there is a new device that is manufactured, I think, in Korea. That I don't know if it has a little canister and it sprays exactly a little spray for a few seconds. It's got a foot pedal on it that it's rests on the skin, and it's the only problem with that is you have to have somebody hold that and spray it. But it would be better. But you know, liquid nitrogen hurts after, you know, if it's too long. You've got to have someone who's really good at that. And then of course the pigmentary alterations that could happen. So for me, I find ice works better, but if you know, liquid nitrogen or some other cold device works,
Liquid nitrogen, you're going to blister people up. You know.
Yes,
One
one of our patients was asking for more and more, and actually landed in the burn unit. They thought he had, you know, with you know, massive.
There's no such thing as not being able to get ice.
Yeah, for the palms, I just recently saw another patient after that patient, and she was also demanding the cold spray. We were much lighter with her given that recent event, but just for people who want that and maybe don't want ice, or for some reason you can't get ice, I just wanted to know if there was a recommended way to do it safely.
do what I did at the very beginning back in the late 90s is just put their hand in an ice bucket until they say it's numb, I can't feel it, and then
Talk about make sure that your ice trays are always full. That has happened to me where I, usually go, oh, take a look at this lovely rectangular piece of ice, and there's nothing. No one filled it. If you kill it, fill it, please.
or I kill you. No.
Yes. GMEs again.
Yeah.
So if someone is getting that treatment on their hand injection, is the type of skin they have make a determination if the treatment is okay for them or not? Like someone is a construction worker, so maybe thicker skin. Does that make a difference?
So for the injections?
Yeah.
Or the iontophoresis?
For the injection.
Yeah, no, they can have thicker skin. It's just harder for the person injecting to say, oh, there's a callus or a thick spot where they're working, but this little part here is very thin. You just have to use your, skills to make sure that you're at the right level, right under the dermis where the fat comes in.
And if somebody has really callous skin, you're going to be numbing your needle a little bit. It might be nice halfway through to change to a fresh needle.
Iontophoresis is cost-effective treatment with minimal side effect and proven effectiveness. Why is it overlooked for axillary hyperhidrosis, despite being cleared by FDA for this purpose?
You should probably give a disclosure that you are.
Yeah, sure.
Go ahead, that you are with the iontophoresis device, so I'll.
But I'm not talking
I know,
about my
I'm
device.
not yours in
Yeah,
particular, I just wanted to share that. So historically, it hasn't really worked well, those little pads, and sometimes they get the burns, they can get some burns. But the shape of the axilla is so varied, and some people have very concave, and they just couldn't get enough contact with it. So I have no experience with your device, in particular treating axilla, but I would say overall, with the past devices, it just hasn't worked as well.
It's all just dependent on that electrode and how it contacts, the sponge type electrodes. It's really hard to get that to fit to the not uniformly concave structure of the axilla, no matter how it's positioned. And then also, there have been times when the metal part of that plugs into the electrode, if that touches the skin, can cause trouble as well. So hopefully this new device is working out with some of those problems, but because it is new and we haven't seen it really, I have not had any hands-on, hands-in, or Axilla in with this treatment. I can't really comment on that.
I have recommended it for people, especially for people who have the device for hands and feet, and they're still having trouble getting their axillary disease under control. I'm not sure that we have so many great options for axilla, hopefully even more, but I think, 15 minutes and it's kind of expensive up front, but it's a very good question.
I think let's break for lunch. Just kidding, let's not break for lunch. We're gonna starve you.
I just have we are gonna break for lunch.
Yeah.
Okay, so we already did our Q&A, right? So I just have a quick announcement because I want to make sure that these people are not here in the room okay. Dr. Berman, is Dr. Berman here for Behrman?
Sick, he's out.
Okay, thanks. Dr. Boger? Okay, and you say? Okay. And Ms. Casillas? Dr. Traeger? Dr. Newkirk? And two more. Thank you very much. I just, if you're here and you passed by the registration desk, I don't know how that could have happened. Okay, and Dr. Catherine Suer is not here either. Okay, so those of you who, now that I know who's not here and accounted for it, those of you who are asking to perhaps be added onto the attending's team for hands-on, and you have an active DC license, we talked about it at the registration desk, you can come and see me when we break for lunch. I'll do my best, my very best, to try to figure it out. That's why
Go Team GLASER!
Lunch is back in 3:09, and when do we?
Patient, the one I was talking about, you had done her twice for me. She was so sad you weren't there. She said you did it by yourself, like growing and alive. I was like, what? She was so sad getting so people. Yeah. It's tough. Believe it. Yeah, depending on the
All right, guys, let's get started. Just we still have a very busy afternoon ahead of us. We're going to continue onward with the fourth act, which is going beyond just hyperhidrosis. What are kind of things we need to consider in unique patient populations? What are some secondary things that can happen? So really taking a 360 overview and review of what these patients are experiencing. And I'll welcome back up Dr. GLASER to start us off.
I don't usually give this lecture, so let's see how it goes. But it's interesting. Lifelong care. So we're going to kind of think about pediatric patients and geriatric patients. And obviously they're different, but they each have some unique circumstances, maybe healthcare issues, financial issues, pain issues, whatever, in terms of what we may choose to use or choose not to use. And if we do choose to use something for treatment, what some of the special issues are that we might need to consider. So I just divided up, what we've already been talking about, our non-invasive therapies, which I put down as topical and systemic medicines. Our minimally invasive, maybe the iontophoresis, the toxin injections, and our TAP patch. Maybe moderately invasive microwave thermolysis, and then the surgical side, which again, for us would be either something with some lasers, liposuctions, devices, and then understanding when we might want to recommend sympathectomy or not. So here's a question. Which of the following topical medications for hyperhidrosis is FDA approved for pediatric populations? think of your own answers, and then when I show you the answer, you can say that you all got it right. It's good. Just everybody, you know, because there's no audience response, so everyone here gets it right. But think about it. Okay, so glycopyrronium, right, is the only one. We can use any of these in pediatric populations. You know, zirconium and aluminum chloride are usually found in our antiperspirants. Glycopyrrolate is not topically, and formaldehyde, which is just a drying agent, is not. And usually, they actually used a fair amount of formaldehyde in probably 40, 50 years ago to treat hyperhidrosis, but it's really not very good. So it's FDA approved down to the age of 9. We talked about, you know, Dr. Harriser showed some of the data on the pediatric patients that were in the clinical trial. Not only did they have as good of an efficacy, but truthfully, they had no worse side effect profile. And to some degree, they actually understood how to wash their hands better than the adults and had fewer mydriasis. So I think this is a pretty good population. There aren't a lot of 9-year-olds that have axillary hyperhidrosis. You know, most of the little guys have Palmar plantar, but some might be having it down to 9. You could consider using it for hands off-label for the little guys, as Dr. Harriser showed you in his adult trial with the cotton gloves. And then Dr. Friedman mentioned the study by Amy Paller with 31 patients using systemic glycopyrrolate and oxybutyn. And that study was actually, for the most part, just kind of a chart review of people that they had treated. And I don't think any of them in that cohort was below the age of 13. I always kind of think of teens as a little bit different than like little guys, little guys. When they're in grade school and stuff. So the teens can then also be sort of some go through puberty a little earlier and some are a little more delayed. But this is, I think, a nice option. If we go the other extreme, what about topical treatments for the geriatric patients? You know, their skin's getting thin, maybe it's getting dry. There can be some other issues with it, seborrheic keratosis, things like that. You know, so these are also agents that are quite reasonable to use in them and probably without too many additional side effects. Really have to stress the washing of the hands. So systemic treatment, again, for pediatrics, and I think Dr. Friedman covered this really well. The slow dose going up slowly. Again, for me, the 5-year-olds, 4-year-olds, 6-year-olds, when they're going to school, how do they know they're not peeing enough? How do they know that their urine's, you know, yellow enough? So they always make me pause, those little guys. The teens don't bother me as much, except for those sports players where they're out there. And I just feel like, you know, the coaches just don't understand. And when you have a sophomore out there who's trying to make the football team or the lacrosse team or whatever, it's a hard one. You have to really think about that. And we talked about why we chose glycopyrrolate typically over oxybutyn, but understanding that many people, if they fail glycopyrrolate, may get excellent results with oxybutyn. And there have been several decently performed studies that have been published. Actually, several of them are by a vascular surgeon down in South America. They've done some nice studies with oxybutyn. And then we talked about how oxybutyn and glycopyrrolate, even though they're not FDA approved for hyperhidrosis, they each have pediatric indications. So there's at least some body of information to point to its safety, and just learning how to use that in that slow way. I will say I've had one pediatric patient that I had with systemic glycopyrrolate that became very excited and almost agitated. So one of the side effects is either kind of slowing down and confusion, and one is agitation. And usually that excitement, agitation is more in the younger patients, and that slowing down is usually more in the adults. So anticholinergics in geriatric patients, again, it can work well. And Adam touched on this one article that was published in JAMA Internal Medicine back in 2015, sort of implying that there was some concern with that and dementia. But when you look at, they just looked at 3,500 patients that were age 65 or older and looked at their brain health over 7 years between 1994 and 2012. So, these are studies that were done some time ago. And they had found that some of the patients who had the highest exposures to anticholinergics, and that was just based on their charts, how much they were prescribed, doesn't really show, they didn't show how much they were actually taking, was 1.5 more times likely to develop dementia than patients who were not exposed to anticholinergics. And it's hard to tell from the article that they did remove things like the antihistamines and stuff as a, quote, anticholinergic in this study. So, I get asked this question a lot, and I think the take-home message is just that we don't know. There, as he said, there's some perhaps correlation, but not causation, and we're going to use the lowest effective dose that we need to use for you to control your symptoms and add other things, So, but you may get asked this, and it's helpful for you to see the actual study and maybe even read it. These are the side effects of anticholinergic drugs, and this was covered, but you can see the last one on the list is that it suppresses thermoregulatory sweating. So we're trying to suppresses sweating and not get any of the other anticholinergic side effects, and that's why it's so important to use the lowest dose possible, and I think usually combining it with something else so that you use the lowest dose. And as I mentioned, in either population or any population, I don't like to use topical and systemic anticholinergics together. I don't care if they're on an antihistamine for their dog allergies or whatever, but I don't want to use a topical as well as a systemic. Okay, which of the following is a contraindication for treatment of iontophoresis? Got that. All right, I know you all got it right. It's implanted cardiac device. And if you do, you could consider, if you really felt like that was the treatment for the patient, is maybe just to do an arm and a leg together, or a foot and a hand, and then do a foot and a hand, so at least it's not going across. But the best thing is to try to come up with another option. But again, sometimes being creative is helpful. Iontophoresis really is a good option for both the geriatric and the pediatric population. History of epilepsy. I had one child who I really wanted to use iontophoresis, but had a pretty significant history of epilepsy, so decided not to, and not to push that. And one reason the pediatric population is such a good group for this treatment is because their parents are very much involved and are really helping push them to get this treatment done. Once they get to be teens and college age students, it's really hard because they're on their own and they can make their own decisions. All right, botulinum toxins are good in both geriatrics and pediatrics. It's not FDA approved, younger than age 18. It is, of course, as we've said again and again, it's only FDA approved for the axilla. The problem with the pediatrics is just the pain. So you have to use not only, maybe ice, topical, vibration. I wind up using a lot of silly talk in the office with them to get their brains distracted. So I'll ask them to count backwards from with sevens or something, or I'll ask them to teach me how to, if they speak a foreign language, I'll ask them to teach me how to count to 10 in French or Polish or whatever. And even if I know how to count in that language, and I don't know that many languages, I'll mess up. And then they're like, no, it's not trois, it's this. And I'm like, oh, do it again for me. Tell me again. And so I'll distract them very much as I'm trying to get an 8-year-old or a 9-year-old to let me inject 50 times into their hand. But it's a tough one. It can be done. And I still think if I can get that done rather than taking them to the OR and putting them under general, is a much better idea. And I do warn everybody with kids, you probably have learned this, is that, you know, their respiratory happens much faster, and so you don't want to be administering things in the office that you can't control. So that's the one kind of caveat. Microwave thermolysis is also FDA approved down to, or at age, I can't remember if it's 18 or 21. Who's here? Is Mario here? I don't know, it's in adults only. 18? I think 18. But I do treat some people younger than 18, and for me, it's not the age, it's how well developed their body is, because I don't want a really, like, at the bottom, these young teens who are very, you know, they haven't matured yet, because I think their nerves are closer up to where they could get some damage. But if I have, you know, a more adult-sized teen, I have no problem. I'm always sure to tell the parent and the teen that it is off-label, that it is technically approved only in those 18 or above, but that I've treated others, and, you know, as long as I think their body habitus is such that it's fine, and I do warn them, and I write it down in the chart that I told the parent and the teen. So I think that was sort of where I wanted to take things with the specific pediatric and geriatric populations. I think otherwise you can treat them very similar. Sometimes parents and children have different ideas of what they want and what they want to be treated with. And so sometimes you need to talk to the parents separately and the child separately to understand what their concerns is. Because a parent may not want to say that it's a financial thing in front of their child. And the child may not want to say why they want a specific. So sometimes I will separate them just to have a little chat with both of them. But that's all I had, unless there were any dying questions. Okay, so the next one, this is the one I'm a bit excited for.
So we're talking about special populations. We just talked about children and older adults. Now we're going to talk about amputee patients. And I know many of those in the room from Walter Reed and perhaps the VA have some experience in this realm. But I want you guys just to think, you know, what patients with amputees may be at higher risk for hyperhidrosis. You guys think it's the older patients, younger patients? Anybody care to wager a guess?
Younger patients.
Younger patients. What about where the amputation is? Do you think that impacts the degree of hyperhidrosis? Now, anybody want to wager a guess? Is it above the knee, below the knee, arm? Above the knee. Okay. We'll dispel that myth in a moment. So I'm glad to hear you guys don't know everything to know about this.
See, they knew everything in mine.
I
know, because I just believed it.
No. So hyperhidrosis, we're going to talk about in a moment. I want to bring it home in terms of, you know, how many patients in the United States live with limb amputation. And it's about 2 million individuals, so 1 in every 150 people. And that number is expected to double or triple by 2050. So this is a population we will be seeing. Each year, there's approximately 110,000 amputations, the majority of which are for vasculopathic reasons such as diabetes or vascular disease, with the remaining 30% being related to trauma, tumor, and congenital anomalies. And my mother-in-law actually is an amputee related to a tumor in her knee, so an above the knee amputee. So have a lot of personal experience as well with the amputee population and how difficult it is to be in a prosthetic device for a full day and all the skin issues that come along with that. In fact, most lower leg amputees, only about 5% use a prosthetic device for more than half of their walking day, which can really impact their reintegration in society and their ability to do a lot of different activities. So this is an issue that we as dermatologists really need to be attuned to. Just so we're on the same page, I'm sure you all have seen patients with prosthetic devices, but typically there is a socket, which is a receptacle for the patient's limb. There's often a liner or sock placed over the limb, and that helps provide a barrier as well as absorb sweat. There's some sort of suspension device that used to be much more cumbersome, like a cuff or a harness, but now they have these wonderful vacuum or suction devices that fit very well. There's often a foot, hand, or hook covering, and then a cosmetic covering to blend in with the skin as well. So it's a multi-component device. And skin health is of vital importance to the functioning of the prosthetic device and for the patient's life. Poor skin health is actually associated with reduced time spent in the prosthetic device and reduced performance. And it's not just something in the immediate post-op period that patients struggle with. In fact, up to 75% of prosthetic patients may have issues years after. There was a study that looked at Vietnam vets in particular and found that nearly 50% had skin issues in the residual limb. That was actually 38 years after the amputation. So this is a major issue for our patients. And in particular, hyperhidrosis leads to significant issues and something we probably don't think about a lot. In one study, hyperhidrosis was the most common reported skin issue in patients with lower limb amputations. So we're primarily talking about lower limb amputations because it's not as much of an issue with patients with upper limb amputations. So most of our talk today will focus on that. And as you know, if you have this chronically moist, occluded environment, you're going to get a lot of secondary skin issues. You're going to get irritant dermatitis, contact dermatitis. You're going to get foul odors and maceration. You guys have probably seen, we have this patient at the VA who insists on wearing gloves at all times, nitrile gloves, and he has this horrible verrucous hyperplasia in response to that chronically moist environment. And you'll see that in other areas too, such as the stump site, as well as ulcerations and pseudocapaces or acroangiodermatitis. So a lot of patients will have secondary issues. And what's depicted here is folliculitis on the stump related to that hyperhidrosis and occlusive moist environment. And more than 50% of individuals with amputations report discomfort related to the hyperhidrosis. Now, why? It's pretty evident, we've just discussed that, but you have this occlusive environment created by both the liner and the vacuum and the sock or sheath. And so you've got a lot of heat developing as patients are mobile, and that occlusion will trap the heat in there. There's nowhere for it to go. That's why patients have excessive sweating. They haven't really looked at if patients had hyperhidrosis prior to amputation. Do they have it after? Is it mainly that population? No. They haven't looked at that in particular, but all patients, even regardless of activity, can be at risk for hyperhidrosis. And not only does it cause skin issues, it also can set the patient up for falls because there's going to be some poor fit and loss of the vacuum for the prosthetic device, and patients may actually slip and fall. So it's not just a skin concern, it's also a functional concern. And I mentioned there are some studies primarily out of the rehabilitation literature where this is, by far and away where this is studied. We don't see a lot in the derm literature, to be honest with you all. They've looked at which patients are at highest risk for hyperhidrosis. And as we discussed, younger patients and those with transtibial amputations seem to be at higher risk. Now, why transtibial? That's below the knee amputation. We don't know. It's not due to the density of eccrine sweat glands. They don't know exactly what has occurred to cause that. In addition, we find that traumatic amputees may have higher rates of hyperhidrosis than those related to vasculopathic causes. Now that makes a little sense because typically it's older patients who have amputations related to diabetes or vascular issues, and perhaps the younger patients who have had traumatic amputations are more likely to have hyperhidrosis or are more active in trying to reintegrate. But that being said, that's the population where we see the highest rates of hyperhidrosis and to be aware of. How do we define it? It's not really a formal definition in the setting of an amputee. It's a clinical diagnosis as we've discussed today. There are ways you can look at the residual limb, and if you see secondary dermatologic issues such as folliculitis, fungal infections, bacterial infections, that can be, of course, a clue. Also, there are quantitative methods. We discussed a little bit about vapometry, which measures transepidermal water loss, gravimetry, and then we talked about some of the scales that can be utilized. And the HDSS is actually quite accurate in determining an amputee's the impact of hyperhidrosis on their life. So that's what can be done certainly in clinic or in clinical settings. You can also do the starch iodine test for amputees. It's a little cumbersome because for a patient to take their prosthetic leg off, they often have to have the vacuum device with them, and it's quite a process to don it and take it off. And so, but if you are going to do this, they've actually done studies to look at the optimal way to do the starch iodine test in the setting of a lower limb amputation. They've done it with saran wrap, and that seems to actually create almost confluent sweating. It doesn't seem to really mirror where the patient has sweating. And so what often is done is the starch is placed on the leg, the iodine is placed on the leg, the starch is put on top, and then the patient can don a prosthetic sheath, walk around for about 10 minutes to recreate some activity, and then take it off. And when you take the prosthetic sheath off, you can actually see on the sock the areas that turn black, or where the patient has usually the most contact and occlusion, and where we see the highest amount of sweating. It's typically the top 3 centimeters of the amputated leg, as well as the distal end in particular, where we often find the highest distribution of sweating. That doesn't mean you don't treat around it, but that's where we typically put the most density if we're, for instance, doing something like botulinum toxin for those patients. And you can see this patient's been marked out in a grid-like pattern for neuromodulator injections. So just to spend a moment, this is a little out of our purview as dermatology folks, but people are doing a lot of research in the rehab world on the components of the prosthetic device to see if they can better offload heat and create a better environment. And so they're looking at the sock, for instance, to see what may absorb sweat most and also provide a barrier. They're looking at the prosthetic liner. They've actually developed some cooling coils within the liner to help with offloading heat. And they have done studies to show that silicone and polyethylene are often the best liners for offloading heat, but there's a lot of innovation potential here. But what can we as dermatologists offer these patients if they come in and see us? And what I did is I looked over all the articles and review articles on treating residual limb hyperhidrosis. And there's not a lot out there. And if it is out there, it's in the rehab literature. One of our colleagues down at the VA in San Antonio will soon be publishing a treatise on how to approach this and treat this. I think it's going to be very helpful. His name is Dr. Hibner, Chad Hibner, if anybody here knows him. But you know, it really is actually going to be in the rehab literature, so it's not even going to make the derm literature. So it's something you have to seek out if you're interested or seeing these patients. And similar to localized hyperhidrosis in other areas, aluminum ion-based antiperspirants are often offered first line, as would make sense. Patients can apply it at night, as we've discussed, which is the best way to apply it, when they have their prosthetic device off. And then the next morning, wash it off. Although, you know, it can be quite irritating and they're using it on a large skin area. So it's not typically well tolerated, but the majority of patients will likely have tried this or should try this first line. Topical glycopyrronium cloths has also been reported in one case report helpful for a patient with a lower limb amputee. She found great benefit from it. It hasn't been written about widely, and I think there are some concerns about systemic toxicity if you're putting it on and then including that environment with the sock, the sheath, the vacuum, you know, and worry about systemic toxicity. And certainly in our older vasculopathic patients who already may have urinary retention, you know, we're not necessarily looking for more of that, right? Same with the oral medications. Recently, Dr. Boger, one of our colleagues, was doing a telederm with a patient who had an amputee and was having hyperhidrosis, and he had said that oxybutynin was by and far the best treatment he'd ever had. He'd had Botox, he'd had this, he'd had that, but he loved oxybutynin. But, you know, so it's worthwhile trying in a patient with hyperhidrosis, but the studies are a little limited, and it doesn't seem to decrease the incidence of skin pathology if a patient has some sort of eruption on the residual limb. And so, again, it's worth discussing about with the patient, but I think, you know, as we've discussed in our geriatric or older population, it may not be a great option because of those anticholinergic side effects. But again, those are not always the patients who are suffering from hyperhidrosis either. So both oral glycopyrrolate and oxybutynin can be considered, but may not be ideal in all patients. By far and large, the most commonly reported medication used for this condition is neuromodulators such as botulinum toxin. And there's lots of small studies and case series between 1 and 9 patients that report this effective. Typically between 300 to 500 units are applied in a circumferential pattern at 1 to 2 centimeter intervals, just like we do in other areas. Most times we can get by doing this just twice a year. Patients are usually able to get some relief, so you don't have to do it maybe quite as often, and usually during the warmer months, depending on where the patient lives. Now, of course, if we discussed, like in other areas, it can be quite painful. Sometimes these patients have phantom pain and other issues. Interestingly, some studies have shown that botulinum toxin is helpful for phantom pain when injected deeper in the subcutis. So there can be benefits patients get otherwise, but this is by far and large the most common treatment that has been written about in the literature. It is very hard to get in the private sector, as I was talking with my colleagues, but in places like Walter Reed or the VA, it may be a little easier in the military setting or VA to get this to treat patients. Iontophoresis, as we've all seen it today, some people have tried it, is available. It's inexpensive, but there's not a device on the market situated for an amputated limb. I was talking with the gentleman here who was CEO of the company that came, and he mentioned that they can actually create a device specific to some anatomy. So he potentially said he could create something for an amputated limb and that people could reach out to him. He's based in Canada, but I personally don't have any experience with that. And there's very few studies on it in the setting of residual limb hyperhidrosis. We all know that laser hair removal can be helpful for amputated patients, especially with getting a proper fit and reducing that hair, as well as if a patient has secondary folliculitis. So this has been written about, but in terms of how it affects hyperhidrosis, there are very limited studies. And some small studies show some benefit. We know that, the laser may help with injuring the eccrine sweat gland. In addition, part of the reason we have hair on the body is to help retain heat close to the skin. And by reducing that, you may not trap the heat in as much. But again, there's very few cases looking at this in particular related to hyperhidrosis. And it can, of course, be costly. It's not always covered by insurance. Microwave thermolysis is something exciting and new in the setting of an amputated patient with hyperhidrosis. It's most recently been studied from our military colleagues when they're trying to get patients back on the field, for instance, quickly. The problem is, the patient has to have either tumescent anesthesia or regional nerve blocks, and they can only do it on half a limb at a time. And so each half limb takes 7 to 8 hours. So it's a really time-consuming treatment. Patients will have a good reduction in hyperhidrosis with a really durable response. It can last a long time. But they also have limited use of the prosthetic device for several months afterward. And so if somebody's trying to reintegrate in society, 4 months out of their prosthetic device is really challenging. So again, very limited studies, but it does look promising for highly motivated patients. Other treatments listed here that we discussed briefly today have not been studied in the setting of amputated patients. And I just thought I would provide the summary table on, again, you see very small numbers of patients reported. This is probably most of the articles using botulinum toxin for residual limb hyperhidrosis. So again, not a large number of patients, but it is very effective. There's different dilutions used, but patients can have an anhydrotic effect that lasts anywhere between 3-4 months or so. And I thought I would share this image. It's from some of our folks. You guys may remember Megan Simpson and Ford at Walter Reed, and they had trialed this microwave thermolysis. And you can see at the top, these are patients immediately pre-procedure. And then the bottom images are patients immediately post-procedure. And there's significant erythema, even blistering. So you can see, again, these are 7 to 8 hour procedures to do half the leg at a time. But I was talking to some folks who have done this on amputated patients, and they said, again, for somebody who's really highly motivated to get back into the field, for instance, which Chad was sharing with me some of his patients who had a double amputee and then went back to serve overseas, this works incredibly well. It's just selecting the right patient to do it. So, just to summarize, this is a really unique population. I think we as dermatologists are a little bit behind the game in addressing hyperhidrosis and the secondary dermatologic issues. We really probably need to be more proactive, doing studies and looking into this. We do have treatments available, but it's really important to help patients reintegrate into society and get the most use of that out of their prosthetic device. And we really need to take a greater lead, I think, in this arena since we are experts in hyperhidrosis and other areas. So with that, I will pass it on to Dr. Friedman.
This is a nice extension because you already heard about how just even these focal areas can suffer from secondary effects of hyperhidrosis. So we're going to kind of go through the gamut of the different areas that can be impacted by hyperhidrosis from the lens of an infectious disease specialist. So what is the issue? Why is this a problem, something we have to actually think about, and something I would actually encourage all of you to ask your patients about in terms of a skin infection, that's a very broad term, skin infection history, whether it be bacterial, fungal, probably a little less so viral, but certainly viral as possible. So this was a study from a journal you will never, ever, 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 ever read, looking at the impact in athletes of sweat on skin integrity. And what they found is with increased sweating, it altered the pH of the skin, but also you can see that the hydration of the stratum corneum certainly went up, which is no surprise. Now, the stratum corneum needs some water to function. The various enzymes that convert ceramides and proteins from their precursors to their active form require some water to work. But you do need some transepidermal water loss. I know there's so much focus, especially in the AD world, of no, transepidermal water loss is bad. It is when there's too much of it, but you need to have some. If you have too much water, the whole thing kind of falls apart. And that also goes to the acidity. You know, our stratum corneum needs to be acidic for all those good things to work, to keep things turning over. And if the acidity shifts, and this is where AD is a good model because the pH of someone with AD, their skin, it's more basic than acidic. Once again, things fall apart. So excessive sweating and chronic excessive sweating could dramatically affect the first line of defense of the outside world. Now, this is an extreme example. You think about trench foot. What's happening in trench foot? It is super saturation of water, in this case, being exposed to water, you know, having wet boots for periods of time. But that white that you're seeing, that maceration, is indicative of that overhydration of the stratum corneum. All right, so with that in mind, hyperhidrosis could equal or lead to supersaturation of water in the stratum corneum, causing it to fall apart and opening the door to the nastiness in the world. So let's now think of infections in general. Now, for bacterial infections, just as a primer, a lot of the terminology we use is based on location. Impetigo to ecthyma to erysipelas, cellulitis, pediculitis, and then fasciitis. It all refers to where that infection is. So just in terms of, especially for the residents, just thinking about the terms you use, think about where this is occurring and the clinical features and the clinical appearance to define what actual name you're going to give this in terms of what type of infection. A lot of things you need to consider in terms of infections in general. This goes well beyond the breakdown in barrier and in external invasion into the superficial layers of the skin. But these are just good considerations for skin and soft tissue infections in general. You know, is it a localized infection? Is it multifocal? This will then, of course, lead to how you think about treatment. What about the host themselves? Already, someone with primary or secondary hyperhidrosis, their barrier could be defective in many different locations, so that's a host factor. But what about comorbidities, things that increase the risk for infection, immunosuppressive states, endocrinological disorders, even thinking about, you know, a stump or an injury or some other thing that can increase the risk for infection. So we're going to talk about some different areas where hyperhidrosis can leave its mark, especially when it comes to skin infections. So most common, obviously, is primary axillary hyperhidrosis. Simple being simple, the common offenders can obviously cause issues. You know, we think about staph and strep, probably staph first and foremost, and staph can cause a lot of these different layer-based infections from very superficial, like impetigo, to the deeper down. And when you think about axilla, hair-bearing area, there could be easy follicular extension. So you start to think about folliculitis, furunculosis, and my favorite, of course, carbunculosis. What a great word for something horrible. And just an aside, you know, we're not, I don't want to skip around too much, but another body fold to think about, you know, bullous impetigo. To be fair, I couldn't find an image of bullous impetigo in the axilla, so I kind of stuck with this, but things to certainly think about, and some board spotter, you know, in terms of what type H group 2, you know, types 55 and 71 are the primary staph species that cause this. They secrete an exotoxin that will cleave an adhesion protein in the skin, just nuclein 1, causing that separation. We more often than not see this in kids and the elderly. So those are some of those factors that you can think about that can increase the risk for infection, throwing hyperhidrosis into the mix as well. But more notable for this location, erythrasma is an infection that really loves this area. caused by Corynebacterium, usually will present as a red-brown, well-defined, thin plaque. Usually asymptomatic, but maybe occasionally pruritic. A Woods lamp is going to be your best friend here that will really highlight the corpoporphyrin 3. Importantly, though, make sure that the patient didn't really wash because porphyrins are water soluble and they will wash this away. This was actually from one of my patients, and obviously did a really lousy job taking a photo, but you can still see the color, even though the photo is quite blurry. Just another example of that beautiful like coral red fluorescence. So when we think about erythrasma, I think we should also consider other Corynebacterium, one of which will certainly be important when we think about plantar hyperhidrosis like Pediatric. So I think it's always good to check for the other flavors of this, especially in this location. You can think about Trichomycosis axillaris, these kind of concretions on the hair that are near impossible to get off. Like you actually have to shave the hair off to really be rid of it. How do we treat it? It's pretty easy. That's the good news. Topical antibiotics, antimicrobial washes are pretty effective, but you have to be able to recognize it and have to even think about it. All right, let's go a little further south to the hands. Paronychia, there are two flavors to this, acute and chronic, and each are caused by different microorganisms. Acute is most notably staph, painful, swollen, sudden, versus chronic, which is indolent, slow, chronic changes. You know, the visual component of this really suggests this has been going for some time, more often than not caused by Candida. So here's a nice example of Staph aureus paronychia. You can imagine that if you were to press on this, the patient would yelp, they'd jump, extremely tender. What are you going to do about this? Well, if you're thinking about the feet, certainly if there's hyperkeratosis that's added to this, you can certainly call a friend in podiatry. Limit friction or injury. I really do like half white vinegar, not white wine vinegar, not red wine vinegar, white vinegar, water soaks, antimicrobial, anti-inflammatory. I have patients just dip their fingers in for a couple of minutes, maybe twice a week, and then take out and apply a moisturizer afterwards. Topical antibiotics I don't think work super well for acute paronychia, but I think chronic paronychia they can work. The inflammatory response can be part of the problem, so I do have these patients in conjunction with antibiotics use topical steroids. I typically don't use a lot of silver nitrate, but it has been reported on the literature. Versus chronic, you know, when we think about Candida, you know, these patients often have a history of having their hands in water, or their hands are the source of water. For example, in the case of Plantar hyperhidrosis, often we see substantial nail dystrophy indicative of that chronicity, right? So an acute event is not going to cause the nails to look like this. This patient's been suffering with this for, I would say, at least, you know, 11 to 12 months based on the changes in the nails. So what are we going to do here? Very similar approaches. When I mentioned topicals before, you know, there are these combination steroids, antifungals. I usually hate these because it's like, let's just treat for everything. We don't know what the problem is. It's like the go-to in a lot of emergency rooms, like could be fungal, could be inflammatory. Let's just go. But actually here, this is a good place to use these because you are you're going after two elements of the pathophysiology. I do find that oral fluconazole can be quite helpful here. And really encourage these patients not to manipulate the cuticle because that's part of the defense, or even mess with the hyponychium, because that's like kind of the barrier to preventing things from getting under the nail, and they have a propensity to mess with things. What is this condition? Anyone? Really? Yeah, it's a mouthful. Erosive nodularis blastomycetica. This is Candida, and it, for some reason, always affects, you know, between the last two web space. I don't know why it always happens like right here or here, but usually it's right here. But also, obviously, barrier dysfunction can lead to invasion. Let's go back to bacteria. Blistering distal dactylitis caused by strep. This is exquisitely painful. These patients sometimes are even febrile and can appear sick. Treatment, you have to IND this like an abscess, oral antibiotics, but obviously it's about opening the door to letting this in. And let's not forget, group A strep gets a lot of headway in the skin. And I think we focus so often on staph, we forget about strep. But strep can do a lot of things. and can be somewhat antigenic for creating more systematized reactions as well. Moving on to the feet with Pediatric in the same kind of category of erythrasma. Hyperhidrosis is one of the leading reasons why this happens. It is a different microorganism that does not create a porphyrin. So taking your wood slime out for this is a waste of everyone's time. So I kind of gave away the answer there. So this is the clinical appearance, but you actually don't need to see it. You can smell it from across the room. This is just awful. Like, definitely don't want to see this patient right after lunch. But I think the whiff test is helpful, but has a very unique, almost cribiform appearance of that breakdown of the stratum corneum, just other variations thereof. And it's not always, it can be anywhere on the foot. I feel like more often than not, we see this picture, but make sure you recognize it on the heels as well. So it is a clinical, I hope you're not going to biopsy this. Keeping the feet dry by doing all the things you've already heard about. I'm not going to belabor that. But then also topical antibiotics like topical clindamycin. And maybe a gel formulation might be helpful because the alcohol base can help be a little drying as well. Now, the other thing to think about with cyanobacteria infections and these superficial infections, that they are the bouncer, so to speak. They have the, that red velvet rope, and they're just saying, hello, come right in, Pseudomonas. Welcome to the party. And so the same goes for fungal infections, that this as a cyanobacteria infection, but then you can get other things. So polymicrobial infection is certainly reasonable. So something to certainly think about. And in thinking about those toe web infections here, this is with dermatophyte, but one we're going to be more concerned about is going to be Pseudomonas, a gram-negative, very hardy and robust bacterium. Can sometimes be picked up once again by that whiff test in terms of smell. But that green color, which is a virulence factor called hyoscyanin, can sometimes be picked up in the nail or even a little bit in the skin, as you see here. So that greenish discoloration can sometimes be a giveaway, but this can then be a portal for septicemia. This moves very quickly. This is, in my opinion, a medical emergency. That kind of malignant pustule. So when you think about this, you obviously want to do everything. You want, easy things by the bedside, which I'll go over in a moment. Do a KOH, may or may not be negative because it's that dermatophyte that may have let things in versus the cyanobacterium. But for Pseudomonas, you're going to need to do systemic antibiotics. And in the ID world, we're starting to see a push for more combination antibiotics just because of resistant patterns. I mean, Pseudomonas is an incredibly resistant microorganism, and it can develop resistance to our limited armament of antibiotics. So there's kind of a push for combination approaches, and certainly phone a friend in ID if you're running up against some trouble. All right, let's talk about tinea. Tinea pedis being one flavor of dermatophyte infections. Commonly, we see dermatophyte infections on the feet because there's no sebum, and there is some innate antimicrobial activity in sebum, so that might be one of the reasons. There are several flavors to this. Interdigital is probably what we see or think of most, like that photo you just saw and you'll see again. But there are a couple different other clinical presentations, like in moccasin type, bullous, and also if you see the feet, make sure to always check the hands. So here's the more kind of classic textbook that we see, and sometimes this could also, you can think about Candida infections. Now, to make this diagnosis, we're going to use our best friend, the microscope and the 15 blade and potassium hydroxide and whatever else, other fun things you want to put in there. This is one of the greatest strengths, being that our target is right there in front of us, accessible. We can do biopsies, we can do bedside diagnostics. You need to be comfortable doing KOH preps because this can make a very big difference when it comes to making the right or wrong diagnosis. I realize this approach, if you're not comfortable, can be daunting and not really sure, well, what am I looking at? And is that really hyphae or is that a cell membrane? One of the things to really remember is that the hyphae, these long branching hyphae, will cross the barriers and boundaries of multiple keratinocytes in your 2D field. So that's what you really should look for, is that the whatever branch you're looking at is really going across multiple cells rather than kind of what you see over here, which can often be confused for hyphae, which are the boundaries of the keratinocytes. And this was actually a paper from, I believe, up the street from Walter Reed, where they suggested, I agree, that don't just rely on one sample. Scrape from multiple areas, do multiple slides, because if your suspicion is high, it's always nice to certainly confirm that. Vesicular tendinitis, if you're going to do a KOH, make sure it's from the roof, because that's where the magic is. You know, as opposed to a viral culture or a zinc smear, you're taking from the base of the ulcer. T-Mantag is the most common cause. You can see dermatophytid reaction, where you have your bullous tendinitis, and all of a sudden these patients erupt with maybe a pseudovesicular eczematous eruption, thighs, bilateral arms. So this can certainly happen here, and these patients often require systemic treatment. And then moccasin type, also a common image shown on the in-training exams, pretty resistant to treatment, unfortunately, pretty chronic. And often we see in combination with this 2 feet, 1 hand, 2 hand, 1 foot. That's why I said always look hands and feet. And of course, hyperhidrosis is going to increase the likelihood of invasion and these dermatophytes making a home for themselves. So some more examples of what this can look like. From a morphologic standpoint, if you see this kind of peripheral annular or maybe trailing scale, never hurts to do a KOH. Always makes my day, should make yours as well. I really love doing KOH, I'm not gonna lie. No conflict of interest, I just threw some joy.
Get alive.
Yeah. Are my kids here? So how do we treat this? Well, we do have antifungals available to us. I think it's important when you always consider antibiotics, antifungals, what is their mechanism of action? Is it static? Static, meaning inhibits, and then you rely, to finish it off, which if someone's immunocompromised, poor vasculature, you can't get cells there, it's not gonna cut it, versus cidal, like the alamines, that will physically destroy the microorganism. For any of these, you're going to treat the areas for at least 2 to 4 weeks, and definitely well beyond when the scale disappears. Not to mention, you might want to identify the source of potential reinfection, most notably shoes, like athletic shoes, pets, other people, clothing, things like that, that certainly should be taken care of as well. Some little tips here to kind of help make these more effective. There's some evidence that cryolytics can help these antifungals get through a little bit better. So this was one study using urea, which is hard to find nowadays, unfortunately. So ammonium lactate certainly would fit as well. Not to mention retinoids, right? What do retinoids do? They thin the stratum corneum. Retinoids have also been shown to improve the penetration of topically applied agents. So this was a recent paper showing the benefits of using a retinoid to get those antifungals in a little bit better. There's not a lot of innovation of late, unfortunately. These are probably the 2 most recently approved antifungals, which best of luck getting them covered. But when you can, they are effective. And I think one of the benefits is that they're once a day versus twice a day. We have to think of adherence as a great challenge, especially for maybe elderly patients or younger patients. So once a day can make a very big difference. And the way I kind of divide these is I like luliconazole for more moist areas and Naftafen gel for more drier areas. I have no evidence to support that recommendation. That's just been my anecdotal experience. I think we do have to use orals periodically. I think terbinafine is a great drug. Please do not be afraid of it. The whole, it destroys my liver. No, it doesn't. You're more likely to get hit by a car than to cause fulminant hepatitis from terbinafine. The main thing you got to know is drug interaction. Terbinafine, beta blockers, not a good mix. So in your hyperhidrosis patients who maybe pop in propranolol periodically, that may be something to certainly consider because that can increase the likelihood for bradycardia. Vesicular also, you need to use oral, and if they have dermatophytid, you're also going to use prednisone as well. So to wrap that all up, I feel like my defeated slide was like totally stolen by David earlier. Damn it. That's that first. Use the tools that you've been trained on. KOHs, cultures, gram stains. It's amazing that we can discover so much about a patient's skin right there at the bedside. Don't only just consider reactive approaches, but also preventive approaches. If someone's disease is poorly controlled and you know their stratum corneum is being obliterated, think about ways to prevent infection. Something as simple as chlorhexidine wash in those areas can wipe away the flora that could potentially invade and go where it doesn't belong. So with that, I'll turn it over to Dr. MAIBERGER.
feels like we're, veering off topic a little, but, in terms of hyperhidrosis today is the theme, but I think the purpose of this is to help us explore all the different dermatologic conditions that may be impacted by hyperhidrosis. So you're thinking about patient sweating and treating those localized or generalized areas of hyperhidrosis, but for a moment now, we're just going to talk about some other dermatologic conditions that may be worsened by significant sweating and hyperhidrosis. So Dr. Friedman has talked about skin infections, and I'm going to talk about some other conditions. I just wanted to share with you that this was a study that looked at patients with hyperhidrosis. I think it was out of maybe Sweden. And you can see there's a number of skin diseases that are represented here in patients with generalized hyperhidrosis, things that we see all the time in clinic, both infections as well as other conditions like eczema and psoriasis, which are of course common in the population as well. In addition, for localized hyperhidrosis, so patients who are having sweating in just a focal area, we see represented a lot of skin issues as well. So these really do go hand in hand. But we're not going to talk about the more common skin conditions that we see. I'm going to talk about some of the rare skin conditions that we see. And I thought I would put this slide in just for us to think for a moment what dermatologic diseases that we see in clinic that are impacted by hyperhidrosis and sweat. So we talked about pediatric, right? This is Haley-Haley. We have, of course, folliculitis, tinea pedis, tinea nigra, have Darius disease. We have hidradenitis suppurativa. We have Grover's disease. We have atopic dermatitis, which is impacted, of course, by sweat. We have miliaria crystallina, which we sometimes see in our hospitalized patients that have occlusion of the eccrine gland in high temperatures. We have tinea versicolor, which we know comes out when patients are in tropical environments or sweating significantly, and intertriginous infections like candidal infections that are certainly worsened by sweat. So the point of putting all these images up here is to remind us that when we're treating a condition like pediatric, we don't want to forget to address the sweat, because that is really a trigger for what these patients are experiencing. So here's a list of some of the conditions that we've discussed, and I'm just going to focus, we only have a few minutes, on a few that I think we really need to be more proactive about treating the associated sweat within these conditions when we're treating our patients. So all of us are familiar with the use of botulinum toxin for patients with Haley-Haley and Darius that involves intertriginous areas in particular. And there have been lots of case reports, and I know Dr. Friedman, and we've done it before as well, and I'm sure you all have, used this treatment for patients, but this was a open label 6-month pilot interventional study. And what they did here is they looked at the safety and efficacy of botulinum toxin A for patients with really moderate to severe Haley-Haley or Darius. They had 26 Haley-Haley patients and 4 Darius patients. It's not as common, of course. And what they did is they treated the areas with variable amounts of botulinum toxin, usually about 100 units, distributed across intertriginous areas. And they followed these patients to see if their disease responded and what sort of quality of life measures and secondary infection these patients developed. And I will say they were just using botulinum toxin as the only treatment. The patients couldn't use topical steroids. They couldn't use naltrexone orally. They couldn't use, antibiotics. So this was really a sole intervention, which is never what we do in clinical practice. And so what they found is that this treatment was very effective, certainly within the first month for about 2/3 of patients, and it actually persisted for about a 6 months duration, as we would expect with botulinum toxin. The most severe Haley-Haley patients actually relapsed, about 37% in the study, but again, they were only using this as a solitary treatment, and that's not how we typically treat patients. And as we would expect, there were no serious side effects. And just to show you a visual, the top patient has Haley-Haley, and the bottom patient has Darius. And you can see at month 0, that's when they initially presented the extent of their disease, month 3 and month 6. So you can see, certainly the top patient with Haley-Haley had really significant improvement of their disease. So just by controlling the sweat, this patient had almost resolution of their disease and could control their disease. And I know Dr. Friedman shared he has a lot of patients he's done this for and had really good outcomes with. If you can get it covered, which is always, a caveat. But I think this is something, again, we don't treat this in isolation. We would give the patient, of course, topical antibiotics and treat any infections. But remarkably, during the 6 months, not a single patient had an infection. And I think that really speaks to controlling the sweat and the barriers, Dr. Friedman said. So something we need to consider certainly in our patients. In addition, topical glycopyrronium cloth has also been reported helpful, as has oral glycopyrrolate in the treatment of Hailey-Hailey. So it's not just botulinum toxin that can be helpful if you control sweat through other methods, whether it's oral glycopyrrolate, or there was also a case report of using topical glycopyrronium cloth. That can also be helpful in treating our patients with Hailey-Hailey here in particular. So something that we need to consider. And I thought we'd just spend a moment talking about hidradenitis suppurativa, because I know this group sees a ton of patients with that condition, and we're always looking to approach this through multiple methods. And so one thing we need to think about is the significance of sweat in these intertriginous areas in controlling the disease. And there have been a number of case reports, but this was actually a study that was a systematic review, looking at hidradenitis suppurativa and treating hyperhidrosis. They found that 16 articles met inclusion for a total of 252 HS patients, so not a huge number. Overall, the results revealed that botulinum toxin improved HS severity significantly in quality of life, and of course the associated hyperhidrosis, and was really well tolerated. So that is an easy intervention, if you're able to get it covered, that you can offer your patients both with and without associated hyperhidrosis in the setting of HS to areas that they have significant involvement, which are generally intertriginous. Suction curettage did not improve the disease. Only one patient improved with diode laser, which is a little surprising in terms of HS severity, because we do use laser hair removal a lot in HS, and anecdotally, I certainly have found it helpful. But in this study, only one patient noted improvement. And as we mentioned earlier, there was a randomized controlled trial looking at microwave energy-based devices that was actually discontinued early due to adverse events with 2 patients developing or reporting med-induced HS. And I wanted to share that image with you guys just so you, I think, kind of reiterate that this may not be an option that we want to offer our patients with HS. Mirror dry and microwave thermolysis may actually worsen the condition. So this is the study that Dr. Parisser was reporting on, where a patient after mirror dry developed an HS-like condition with numerous sinus tracts and inflammatory nodules in the axilla. And so that study was actually stopped early. And there was also another case report of a patient with an HS-like condition occurring after microwave ablation. And so, it's important that we counsel our patients who might hear that, if I'm not sweating as much, maybe my HS will improve. We want to counsel them at this time away from microwave thermolysis in the treatment of their condition. And in our last minute, I just wanted to finish with one other disease that I think we need to approach and think about hyperhidrosis when we're treating these patients, and that's dyshydrotic eczema. When patients have coexistent hyperhidrosis. So if you're seeing a patient with difficult to control hand eczema and they're telling you that they sweat a lot, you may want to consider targeting the sweat as opposed to the inflammation in order to get improvement. So this patient, you can see on the top image, has pretty significant hand eczema diffusely. The patient, this is their starch iodine test, so you can see it's pretty widely positive. And this is the patient after getting treated with oral oxybutynin. Really significant resolution of the inflammation. So again, not every patient, are you going to offer this to, but if you're, you've tried steroids and they don't want to do a, potentially a systemic, and you've really run out of options, asking about hyperhidrosis and sweat, consider doing a starch iodine test and giving them oxybutynin may be beneficial. And also there's case reports of using botulinum toxin in this setting as well for patients with dyshydrosis. And this patient also had significant resolution of disease just by targeting the hyperhidrosis. I think, we hear stories of patients who report their sweating is so severe. And I think just, when we approach patients with hyperhidrosis and we're treating their other derm conditions, we want to think about this. All that you're going to learn today and all that you're going to practice later today is part of our armamentarium in caring for them fully. So I will leave you guys with that and move on to the next lecture. Thank you.
Okay, so we've talked a little bit about the operation of the practice of hyperhidrosis treatment in the clinic. And I want to spend a little time talking about this a little more organized session about reimbursement and issues and how to manage the clinic. So what makes an efficient clinic? Well, you really have to have staff and physicians or physician extenders and practitioners and medical assistants who understand the problem. And it's always nice when you have some staff members who themselves have the condition, who have various are able to talk to the patients about it. It's important to try to develop a relationship with the patient and ask the right questions. I think I said yesterday that when I see a patient with hyperhidrosis, I always ask them the question, what would your life be different today if you didn't have hyperhidrosis? And then after the patient cries, they then tell me what that would be. And I write that down in the chart, and that becomes my treat to target. I want to be able to wear the powder blue shirt or to hold hands with their boyfriend or whatever it is. We talked about the setting of expectations. It has to be realistic. You can't expect the patient that everybody, you can't expect that everybody is going to get 100% better. Nobody really does. And the patient should understand that that's the case. The IHHS has a lot of great patient-facing materials, the hyperhidrosis practice toolkit. They'll send it to you if you ask for it, and a lot of that is helpful. Also, those of you who are here should register on the clinician finder of the IHHS. You will be acknowledged that you attended one of our master classes. That will show your face to the 50,000 or so people who are on the hyperhidrosis website, that you know what you're doing and you have available various mechanisms. Okay, so this is one of the things one of the things that you can get. These are part of the patient toolkit. I think even in the syllabus for today, there are these QR codes. Scan them, and you'll be able to order all this stuff that you can get. Patient referral letters, welcome letter. We have some people that can give. Those of you, we all use electronic records these days, but it's nice sometimes to have patients fill out a form. You want to try to include an electronic version of this. I don't have an electronic version, but it is nice to be able to have all these questions answered from and then you need to discuss with them. These are very issues. Okay, so telemedicine, I think we're going to hear a little more about that from Dr. Friedman, so I will skip that, but it is something that really can be helpful. The clinical study that I mentioned to you earlier on the Palmar hyperhidrosis, topical 120 patients, were all done by telemedicine. We didn't see any one of them personally. We saw them by telemedicine, and not all of them even visually by telemedicine. So, okay, so get to know the payers in your area. If you are in the kind of private practice or any kind of practice that's dependent on the payers, get to know which ones will pay for what, so that you can unfortunately limit the choices that you give to a patient to something that they are really realistically going to get. Payers don't really understand all of this. The fact that we're getting more and more literature is always helpful. Payers like to have published work. They like it to be double-blind and see what the something. But for example, in the Haley case, there's a lot of literature on Haley, and I personally have actually almost always gotten coverage for Haley based on the published literature there. Try to make your chart notes reasonably uniform about this. State what the medical necessity is going to be, what previous treatments have occurred, why they're not appropriate, or unless the patient had some concomitant disease, they shouldn't have it, or they had some sort of side effect. And please don't ever let payers define for you what is a failure. Failure is, I said it didn't work, or the patient said it didn't work. I don't want to have to see a 50% improvement in gravimetric testing to a 50% decrease in sweating by gravimetrics to demonstrate failure. So the patient has a rare form of medical insurance. It says in there. We've been over what the first line treatments are going to be for the various areas of the focal areas. How long is it reasonable to try? Well, you can't expect patients to say that they're, well, I use this, whatever it is, for a week and it's not better. That's part of the realistic expectation that you need to set. So there are some guidelines. The Hyperhidrosis Society has therapeutic guidelines based on each focal area. In the QR codes, you can get that, and it'll show you which treatments for which focal areas are considered. ICD-10 coding, there are codes for primary focal hyperhidrosis in these various body areas, and you should use the most specific code as possible. That's helpful in understanding what you're treating. There are also CPT codes that are important for you to use. The evaluation management code that you use when you first see the patient is important. When you have the patient back for treatment, depending on what it is, whether you can charge a evaluation management fee in addition to the microwave thermolysis. If you're going to do that, of course, that's cash pay, so it doesn't matter. Botulinum toxin injections, there's always going to be a separate charge for the fee for the injection itself, as well as for the service. So if applicable, and you're doing anything else, be sure you use a 22 modifier. So the botulinum toxin code injections, and there's a very long and gruesome story about how these codes were developed. But the chemodimabation of eccrine glands of the axilla, 64650, 653, other areas, scalp, face, and neck, and then unlisted. Well, what happened to the hands? Where and feet? Where's that? And over a glass of wine or beer, I'll tell you what happened at the AMA CPT code meeting where they evaluate the codes when they used to accept those other codes, and I'll tell you why. So there's two ways you can do this. If you're in private practice, you can buy and bill, meaning you can buy the toxin, do the paperwork to try to get it pre-authorized. You can perform the injections, you can bill the insurance company, and you can hope that you're going to get paid for either one of them, even if you've gotten certification, or even if you have gotten yes, this is a covered service by this patient's insurance. But they may come back and say, well, yes, it is, but it was not appropriate for this patient because you didn't try X-Layer Z first. So I don't ever do this. Now, people who do a lot of cosmetic procedures and have a lot of cosmetic Botox on hand and are not used to, and are used to buying the stuff and then billing for the patients, they do it this way. But I don't want you ever to do that. I want you, if you're in private practice, I want you to prescribe the Botox like you would prescribe any other medication. Send it to the specialty pharmacy. Let them worry about whether they're going to get paid for it or not. But then they'll send it to you in a nice cooler box. We put it in your fridge. And when you have that, then you know it's going to be covered and you schedule the patient for injection. This was my freezer one day. Just happened to snap a picture. Every one of these is a vial of Botox, in this case, Botox, botulinum toxin, that was sent for a specific patient, labeled as though it was a prescription. That's the way to do it. So sort of to conclude the whole stuff, this is really the whole day. I hope you've learned that treatment of patients with focal hyperhidrosis is easily learned. There are a variety of modalities that we can use. It leads to a great improvement in patients' quality of life, as much as improvement in quality of life as anything else we can do in dermatology. It can easily be integrated into an office of clinic practice. Iontophoresis, microwave thermolysis, can be done by trained medical assistants. Botulinum toxins can be done by non-physician clinicians. In my practice, most of the botulinum toxin injections for all body areas, perhaps except craniofacial, are performed by PAs and nurse practitioners. In my practice, all of whom I have trained, some of whom, including one of them, is here today in this course, are very well trained and versed on how to do it. And it's an economically viable prescription. So there's been a lot of new options for treatment recently, and that's after years of neglect and innovation. And we're going to talk about that pipeline in a minute. I just want to show, this is a very old slide, but it shows the DLQI scores of many different dermatologic diseases that we can see. And as you can see, hyperhidrosis of the palms and axilla have higher DLQI scores, therefore worse quality of life than any of those other serious diseases that we know to treat, psoriasis, atopic dermatitis, etc. All right, so take-home pearls from this. Primary hyperhidrosis, 4.8% of the population, about the same as psoriasis. Teenagers are disproportionately bothered. Aluminum antiperspirants work better when applied at night. Remember that tonight? Put your antiperspirant on tonight and your deodorant on in the morning. The glycopyrronium cloth is a first-line treatment for axillary hyperhidrosis, along with aluminum antiperspirants for patients as young as age 9. When using the glycopyronium cloth, be sure that you wash your hands, wash, and don't touch your eyes or your mouth. Learn about the systemic anticholinergics and the role that they play. Microwave thermolysis for the permanent result. Those people who are going to be satisfied with an 80% reduction in their sweat. ETS treatment of absolutely last resort, and the gold standard treatment anywhere on the body is botulinum toxin. You can dry up sweat anywhere. We're going to finish it up with something that's relatively new, and that is the access by telemedicine. I think this is an exciting way that we can serve more patients than ever with this condition.
All right, guys, you're almost there to hands-on training. Before we get there, I want to echo Dr. Ferris's comments in that I think we're kind of selling into where telemedicine makes sense in our practice, and I think that the management of hyperhidrosis is absolutely one of the more obvious ways to utilize this technology to help our patients maintain a connection with us. So first and foremost, I want to thank the AED because they have this incredible resource tool on their website that kind of gives updates on everything from, what are the current regulations, waivers or lack thereof, but also some best practices even when it comes to billing. So certainly utilize this website if you have the opportunity. Now, I feel like it doesn't seem that long ago where our anxiety was relatively high because we didn't know what was coming next. And every cough was COVID or brain cancer. And, there was a lot that we had to consider when it came to the practice of dermatology in terms of even being able to open our practice, ourselves, but even our staff being out for at least a week, if not more, with a positive test. And so with that came some silver linings in that, telemedicine has always kind of been rooted in dermatology. We're a visual field. If you look back, there have been so many papers published, especially at a pen, about the utility of telemedicine. But while we knew about it, we didn't really employ it. It wasn't really central. I will say at the VA, this has been something that the residents have been exposed to for some time. But with the drop of the hammer of the pandemic, the state of public emergency went into effect, which really pretty much threw all the rules to the wall. And that, hey, it's the Wild West now. Feel free to see a patient in California on telemedicine, not be licensed there, and yes, you will still get paid for it. So when this happened, we were like, this is awesome, but what do we do? How do we really employ best practices to ensure that we're doing this the right way and maintaining high level care, not endangering our patients, but also not endangering ourselves. This was actually a picture of the very first telemedicine visit I did during the pandemic. Neither of these MAs actually are still even here. This was several years ago. But I think we've come a very long way. And I think what we realize is there are, just like anything, there are a couple different ways to employ an approach. And so with telemedicine, you can do live audiovisual, you can do phone only, you can do store and forward, where someone sees a patient, they take some photos, put some information together and send it to you, and you deal with it later. And I think depending on the scenario, there's no one perfect solution. I think they all have their role. It's just being aware of how to use these and in what scenarios they could be best employed. As I mentioned before, telemedicine or teledermatology is no stranger to our specialty. And I think, we were so equipped to transition when things shifted. And I'll say here at GW, the word came down, cancel all in-person clinics, all patients done. Literally the next day, we converted at least 70-80% of those patients to telemedicine visits. And I think we have a unique ability to do that, but also to maintain it. And once again, devise appropriate ways to use this.
And our patients appreciate it. This was a satisfaction study we performed well into the pandemic of, I think, like over close to 1,000 patients who underwent televisits. And uniformly, they really liked it. Certainly, there were some challenges that we all face when trying to get our patients to use this, whether it be having Wi-Fi, appropriate bandwidth, lighting, just overall wherewithal to utilize an iPad, a computer, what have you. But overall, it was a great way to stay in touch with our patients. But now that we are so far into things, and while COVID certainly is out there, we don't have the same threats as we did before. Now it's about where are the right places to use telemedicine. And I think some of these seem obvious, and probably you're all using these already. And I'm not talking about improving access to care in areas that are underserved. I mean, just in our standard day-to-day. That's a whole other kind of area. But what are ways to better optimize everyone's time? Isotret follow-ups, no question. And I know many of you just recently saw there were some updated guidelines and elements to the iPledge program, which are going to be so much easier for us to follow. Biologic follow-ups, refill follow-ups. You could do a whole clinic on refills doing telemedicine. But what about hyperhidrosis? I think hyperhidrosis is an amazing marriage in medical matrimony. I think that a lot of what we do when we're talking to patients, it's that we're talking to them. It's a clinical diagnosis. Not to say that the tools of the bedside, like gravimetric detection, which I know you love, Dr. GLASER, but most of us don't do that in our practice. A lot of it is that questionnaire we talked about earlier. So I feel like telemedicine is certainly enabling to ask those questions and to set things in motion. Obviously, procedure-based approaches, devices, that's can't do telemedicine. But certainly you can do follow-up that way, after doing a procedure in terms of keeping tabs. Why do you have to drag someone in to hear how they're doing? You can certainly use telemedicine to hear about their progress. Now, I think for each approach, there are different timelines and different things to consider with respect to that follow-up. But once again, I think that it's a lot easier to get someone on audiovisual or even by phone. And you can, depending on the timing, you can actually still document and bill for that time, because your time is certainly valuable. So I think depending on what you're doing and the expectation of how someone should respond, the time point for that televisit will vary. And when I say telehealth, I also do mean asynchronous. So someone sending a message and even just a way, very historically, for example, really bad atopic derm patients, first visit, they're a hot mess. I'm doing all these different things, maybe intramuscular kenalog, starting a systemic agent, and I want to see them back in several weeks to check on them to ensure adherence, but make sure they're doing better. Now I can use the portal to hear how they're doing and not drag them out just for them to tell me I'm doing fine. So I think that there are ways to better optimize our schedules utilizing telehealth visits, because I think also televisits are often much shorter than in-person visits. I think we have lots of challenges still. I think that we can't assume that everyone has the same access to the technologies that we have. And that when I say technology, I also mean the Wi-Fi, broadband, but even just the kind of fun of knowledge of how to use this approach. I recall during the pandemic, I'd hear some of our schedulers offering telehealth visits, and on their side, I don't know what that is. I don't want to figure that out. No, I know. I'll just wait till I can come in. There's a fear of the unknown, and so that can play a role in how well a patient will adapt to this approach. There are some, of course, up and coming changes to our ability to do telehealth outside of areas where we are licensed, as well as for reimbursement. But I think that we are getting better. We're not as high-strung and kind of pulling a beautiful mind, but we need to know what's coming next. And so there are some updates coming down the pike in terms of what we're allowed to do. So until the end of next year, the restriction, and a lot of what payers follow is what the federal payers like Medicare follow. So a lot of what we're doing now we can still maintain. However, we cannot do any televisits in areas that we're not licensed. Come the end of next year, however, we're going to see probably some very big changes. We are still allowed to do through next year audio only, especially if, let's say, you try to do an audio visual and the visual is not working, you can just get them on the phone and still document and bill as though it was a normal visit. So that extension, I think, is certainly good. Even though we're out of the state of public emergency, that waiver is gone. This is going to be revisited at the end of next calendar year. But what is going to change imminently end of this month is place of service. So, for example, let's say you are licensed in DC, but you live in California. Living in California cannot do a visit after the end of this month with someone in DC, even though you're licensed there, because your place of service is technically going to be in California. And so that can make it a little trickier if you're doing remote visits, in terms of you have to physically be at the place of service you're billing. So before, you could be anywhere. You could bill under your institution or your practice and be across the country, and that was fine. That is ending at the end of this month, unfortunately. But then, as I mentioned, a lot of the other stipulations in terms of what you could do. Now, granted, you could bill under your home address. So your place of service, you can bill under your home address, but then when patients get their explanation of benefits or EOB, guess what? Your home address is on the EOB. I don't know if you necessarily want your patients to know where you live. That doesn't always end well. So I think that we need to really keep the momentum going in terms of how important this approach is to maintaining care and enabling access to care. I think we have some time to figure that out. But I just want everyone to be aware of the changes that are about to happen. The biggest one being, where you are when you do that visit, even if you're licensed in the state where that person is, you're gonna have to put wherever you are as the kind of site. But then everything else is kind of being postponed until the end of 2024. So I really do think that hyperhidrosis is one of those diseases for which telemedicine is very meaningful. I think there are a lot of things we can't do well with telemedicine. Skin cancer surveillance, spot checks, yeah, that's not going to fly. But I think given this is more of a discussion, asking the right questions, assessing for impact on quality of life, degree of sweating, I think telemedicine could easily be employed here to ensure adherence, but also to improve the overall patient experience. So in the last couple of years, we went from this to this, and I hope that we can maintain this as part of our everyday practice, and I'm hopeful, and I'm pretty confident that we will be able to do so. Thank you. Is there one more, or?
Here's one more.
One more, okay.
So I mentioned that after many years of coordination, there have been some things that have been happening recently. And I'd just like to talk about what's ahead. What can we look for in the near term? What can we look for in the longer term? The next thing that we're going to see in our armamentarium is another topical anticholinergic called soft coronium bromide. This is a so-called retrometabolic agent, which is designed to degrade quickly when it hits the bloodstream, and theoretically would have the same effect in the skin as other topical anticholinergics. So you get a better therapeutic effect with fewer systemic side effects, and we'll see whether that really is the case or not. The clinical trials that were done for this one were a 2-point improvement in another different patient-reported outcome, other than the HDSS and other than the one that glycopyrronium cloth used, because the FDA is now requiring that. And it did show a statistically significant and clinically relevant improvement with the use of this preparation, the soft coronium bromide gel, in both the PRO and the gravimetrics from the placebo. Those people who got greater than a 70% improvement, you can see there were a third or so of the patients, 70% improvement, and much less for the patients. Treatment-related side effects were mild, moderate, severe. I could have shown you the same set of side effects for the glycopyrronium cloth, and you wouldn't have known the difference because they're almost the same. Now, theoretically, the retrometabolic line should have caused less side effects, and the argument that is made by the manufacturer as well, we're a 15% solution, and the other guys are only a 3.7% solution, so they're better. You can argue that however you want. But it was it's going to be a product. It's going to be available, and again, already approved in other countries. I'll show you in a minute. And it's the 15% gel in a pump applicator is what we're going to get. Okay, so this is the first study I showed you was a 4-week study. Over the long term, the soft-parodium gel basically did work. It worked just as well. No additional side effects that were not expected. Again, here are the same ones: blurred, dry mouth, psoriasis again in some people. Okay, and that was the efficacy was maintained over 48 weeks. Soft-parodium gel is already approved in Japan. Here is the Japanese version of it. It's called ECLOC. And it is being studied for Palmar hyperhidrosis as well in Japan, and pediatric hyperhidrosis as well. So their studies, this one will have more broad indication perhaps if those studies are finished in time, but the initial approval is only going to be for adults. This is something that's really very interesting to me, which is currently languishing in the world of pharma limbo somewhere. And this is an interesting oral combination drug, a combination of oxybutynin and pilocarpine. Well, what does pilocarpine do? Pilocarpine is oxybutynin, of course, as you know, is an muscarinic antagonist, and pilocarpine is an agonist. And the way this thing is formulated is the pilocarpine is a delayed release by about 30 minutes, and oxybutynin right away. So theoretically, you take this pill, it should work on your sweat, and it shouldn't do and it should help with the dry mouth by stimulating salivation. And in a very complex multi-crossover study, which you can go nuts reading, a small number of patients, they in fact did show that the combination drug, insert in the middle there, changed the HDSS just as much as the oxybutynin by itself, and better than the placebo, but had less dry mouth. So this is something which is interesting to see, and hopefully this product will come out of purgatory or wherever it is, and become something that we will be able to use. Very little side effects for this, and nothing different from what we would expect from oxybutynin. Here's another one that's a glycopyrrolate cream. It's available in Europe and some other countries, and it's not available in the US, although I think you can get this online if you really want to. It also comes in a pump, and it was developed for axillary hyperhidrosis. There's a craniofacial treatment, which I was unable to find any kind of scientific information about this in South Korea, called Topical, which is marketed as an over-the-counter drug for facial use. And I wonder how many blown pupils that oxybutynin in a gel is being studied in Israel, and the spray is being studied in Brazil. The 20% formulation is being studied for Palmar hyperhidrosis, and a 1% gel, this is a nanoemulsion gel for hyperhidrosis as well. Interesting medication that is maybe coming along, an interesting technique, and that is with this botulinum toxin, and a different one than we're used to seeing now, which has already been shown to be helpful for cosmetic crow's feet when delivered with multi-needling topically. Microneedling when it's done topically. So there's a phase 2 double-blind placebo-controlled real trial for hyperhidrosis is being planned for axillary hyperhidrosis. And this is something else that we could be excited about if we get a topical toxin that actually works for hyperhidrosis, let alone for cosmetic use. Okay, other interesting tidbits. Topical aluminum chloride combined with botulinum toxin injections for residual limb hyperhidrosis. This one is a VA study that I don't know if you're aware of this one, Mary. I don't even know where it's being done. I haven't seen any data on this one, just the reference that it was happening. Comparison of glycopyrronium cloth with the glycopyrronium bromide cream. No data yet. And Stanford has a management of Palmar hyperhidrosis with Iontophoresis using hydrogel electrode pads. And that's another thing I don't have any data on. By the way, the difference between glycopyrronium, glycopyrrolate, let me just clarify this. The chemical name of the drug is glycopyrronium bromide. The generic name of the drug is glycopyrrolate. Okay? So if you see glycopyrronium bromide, that's the chemical name for the drug called glycopyrrolate. All right, the Korean botulinum toxin, Meditox, is actually, I'm really trying to get them to study this. I've had a little bit of relations with this company, and they think they're going to try to do it for hyperhidrosis. So we do study for other areas of the axilla. Mass General in Denmark, lasers for hyperhidrosis in a real study. Brazil is doing different treatment techniques for Palmar. Lebanon has 6 injection technique, and Greece is doing oxybutylate chloride. So you can see there's a lot of people interested in this. A lot of countries are very much interested in it. And still more topical methenamine, and the Althera system, which is used for cosmetic reasons, ultrasound. There was this mecalamine for Palmar hyperhidrosis. That study was stopped. Development was stopped. This is something that's already used for, I'm not sure, but we're doing that study and it was working well, but they stopped that for some reason. And I already told you about the topical botulinum. So my little limerick that I developed for this is that a girl with sweat stains on her shirts said, "People shun me and it hurts. But treatment was done and now she has fun. She goes out to bars and she flirts." I have some more poetry insights that I've written you. All right, so we are finished with the didactic portion of this. I'm sure you're all experiencing hot rod and hyperhidrosis. So we're going to proceed to do the hands-on demonstration. The way this is going to work, and Lisa is in here, she will correct me when I make a mistake.
Oh, yeah? No, go.
All right. So you should all have on your badge, those of you who are injector trainees, should either have a GLASER, a GLASER, or a FRIEDMAN MAIBERGER, but I will root. And that is the station through to which you will go. You will have live patients with various forms of hyperhidrosis at each station. You will all get to be the ones who are on the giving end of the syringe to inject these people. You will learn how to do the axillary, Palmar. We have inguinal and submammary to do. We'll also have some demonstrations about the microwave thermolysis, not a real one, but a sham of that. We'll also have demonstrations of the tap patch. And I think we can proceed to the room, which is where we had lunch, believe it or not, as we instantly transform the treatment session.
I don't even know what you guys like literally everything. So Sarah, I saw your TikTok like I was 3 years ago. There's something that says like it says commented right on a bird.
Sarah, I got a present for you. Bella, it's nice to meet you. Have you ever seen Athens? Oh, well, those zeros and rows. You get no. It's your athlete. I just get athlete. Like father something there going out.